You're very busy folks, and so thank you for that. Staff, thank you for all your hard work of putting this together. And conferees, I'm looking forward to hearing from every one of you. So let's get started here. First thing we'll start with is Seth.
Good morning, committee. Clicker here, or okay. Yeah, my name is Seth Kilber. I'm the Assistant Commissioner for Kansas Department of Age and Disability Services, Long-Term Services and Supports Commission. We are we oversee, our commission oversees the 7 home and community-based services waivers that we have here in the state of Kansas. And today I'll be providing an overview and this morning of the IDD waiver and some updates on the community support waiver. So kicking us off, right now with the current IDD waiver and waitlist trends, I think it's helpful for the community to understand that on average, we add about 70 people to the waitlist per month. The last offer round we had was in April of 2025. We had sent out 194 offers. The waitlist dates from those offers were from July 21st, 2016, all the way up to the end of December 2016. The next offer round we are planning to get out is late this month and into October. This will take us up through a waiting list date of September 30th, 2018. This will be about 293 offers. So you can see there that when we get through this next offer round, it'll be about an 8-year wait for folks on the wait list. So it's that last date of somebody waiting. That's where we kind of are able to estimate how long a person has been waiting on the wait list. So we'll be about 8 years at the end of this next tranche of waiting list offers. And then over on the right-hand side, back. On the right-hand side, you can see our IDD waiver, what we're currently serving. We have a current participants at 9,667, and we can go up to 9,811. And our IDD wait list is currently sitting at 4,934, and we do have a budget proviso that we really are trying not to go above 4,000 on the wait list. This is a chart showing our projected IDD wait list. You could see on the left-hand side there that in December of 2020, we were at 4,464. You can see how it was continually rising through December of 2023. I think we got some slots filled in fiscal year 23 that took us down to 4,320 in December of 2024. And this is our current wait list there in September as of today is sitting at 4,934, and our projections for June of 2026 reduced down to 4,482 due to some of the slots that the legislature had appropriated in the last session. And then we are still projecting an increase into 2027. So some updates on the community support waiver. This is born out of a recommendation from the 2022 Special Committee on the IDD Waiver Modernization. After a hearing of 3 days of testimony from participants, families, stakeholders, folks on the waiting list, providers in other states, the budget provisos from FY24 and FY25 directed KDADs to apply for a new waiver with CMS. So we've actually brought on a contractor to assist with the development of this new community support waiver, or CSW for short. This is really intended to be a lighter touch waiver. We've also hired some internal CSW staff Because it's going to be a lighter touch waiver, we're really hoping that it'll be something that can help to address our extensive waiting list. As you saw in the previous slides, that without funding, we are anticipating increases to the wait list. So we're really hoping that with this new waiver, we can start to see we can serve more folks and hope to see a reduction in our wait lists. So it will have a $20,000 annual cap per participant. So that means a person can't really spend beyond $20,000 in a year on their services, compared to the average annual cost on the comprehensive IDD waiver, which sees about $70,000 annually per person. So we're really targeting those folks who maybe don't need a full menu of 24-hour support and care to be able to really meet their needs. So it's going to have a wide menu of services as well, things like non-medical transportation, employment supports, personal care services, respite care, various therapies, behavioral, occupational, speech and language therapy, just a number of services that folks are going to really be able to pick, mix and match on ways that they can then maximize that from that $20,000 budget to really meet their needs. So on a community support waiver update, again, thank you to the legislature for providing $953,000 in SGF to be able to launch this community support waiver. This was appropriated in the final quarter of fiscal year 26. With CMS approval, that'll total $2.5 million all funds and be able to serve 500 individuals in that first year. Again, because it is a capped waiver, it'll be $20,000 annually. So that's how we're doing some of that fiscal modeling. Work on the waiver is continuing right now through stakeholder input. We are right deep in the throes of drafting the actual waiver language. I don't know if you've actually opened up any one of those waivers, but they are 200-300-page documents. Really great reading if you can't sleep at night. But it's going to include, we've got a technical advisory group or a tag that we take all of this language to, so we're running it through them, and then it goes through, a bunch of other processes, including KDHE review. We're sending stuff to CMS in advance to hopefully speed up their review when we formally submit it to them. So we're really just in the process of gathering as much feedback as we can to make sure we can really operationalize this and hit the ground running when we've got an effective date. So we've got the services have all been designed and picked. So we've got the full menu there. It's we've completed a rate study, so we're in the finalizing the rates that are going to be developed in the waiver, and still aiming to apply to CMS for this waiver later this year. However, House Bill 2240. From the last session is something that is another factor in this that we will have to potentially take to the legislature to receive approval before we can formally hit that submit button to CMS. So on this slide, you can see a chart of the estimation of the cost, both the average annual cost on all funds, and then what the SGF breakout would be. So, again, with that $20,000 cap, we're estimating 500 in the first year that we're able to serve. For the full year, it'd be about 10 million all funds, with 3.8 million being the SGF. And then in the final year of the waiver, we're hoping to be able to serve up to 3,500 folks. With 70 million all funds and 26 million, just shy of 27 being the state share of that. On this slide, we've got just a short little chart to illustrate how the community support waiver creates capacity for the system. So if a person is on the wait list and the community support waiver is a good fit, maybe they don't need the full comprehensive waiver, then they can, in short, raise their hand and say, hey, I'd like to get on that waiver. We put them on the waiver, wait list numbers reduced by 1. If we still have slots available after, trying to get folks off the wait list onto the waiver, we will then turn our attention to the comprehensive waiver and see if there's anybody on that waiver who would be maybe a better fit for the community support waiver. Maybe they don't utilize as many services or whatnot, and if the new waiver is a good fit for them, and then they can come over, that frees up a slot on the comprehensive waiver, which then means somebody on the IDD wait list who maybe needs that full comprehensive support can now come onto the IDD comprehensive waiver. And so again, net benefit is a waiting list slot reduced by 1. So the idea is we've got 500 slots that we're going to be able to serve on the community support waiver. So our wait list should be reduced by at least 500 from that standpoint. And then, once we have ramped up and gone to, say we're at full capacity on both our comprehensive waiver and our community support waiver, how we're going to manage that is with a single statewide IDD waiting list. So if you've got somebody who is on that wait list and a slot becomes available either on the community support waiver or on the comprehensive IDD waiver, and basically we'll go to that person and say, hey, we've got this slot available. Is this what you want? Is this available? Is this something that can meet your needs? And they say yes. So they can accept that offer by working with their CDDO, and the wait list number is reduced by 1. If they're on the IDD wait list and that slot, whatever it might be, isn't going to meet their needs, then they can obviously decline that offer. So we're not going to force anybody to accept the slot that happens to be available, but they can remain on the wait list until the slot that they do want on whatever waiver does become available, and then we can go down the list and offer it to the next person until we find somebody who does want that opening. So the way we will be managing that is either way that happens, if a slot's available, the wait list will be, eventually reduced by 1. So just to illustrate, what I mentioned earlier about, the community support waiver reducing the IDD wait list, you can see on the left-hand side, that's our current IDD wait list numbers through our June 2027 estimate, and then that's if nothing were to happen with the community support waiver. But on the right-hand side, presuming we are able to serve 500 people in that first year, we would expect to see, that wait list estimation reduced by 500. So pay attention mostly to that 2027 June estimate number there. So that concludes my morning presentation, and I will open it up for questions.
Very good. Thank you, Seth. Committee questions? Representative Bueller.
Thank you, Mr. Chair. Thank you, Seth. You may have answered the first part of the question I have. On slide 5, you've got the 4,722 June of 2027 estimate. That would be the IDD waitlist numbers. If the community support, and that is contingent upon the community support waiver being approved, correct?
Correct.
So when would you expect, again, for that waiver to be approved? And aren't there other dynamics in play that could actually make that lower? I guess what I'm asking is, it seems like over time, this is either a very static number or people drop on or fall off or get back on, either for a number of reasons. So I'm just trying to see what the fidelity of that number is. And then second part of that question would be, I want to make sure I understand the funding needs on slide 9. So the first part is that estimate only going to go down 500, or will it go? Does it have the possibility of going down even more with, excuse me, if the CSW is approved? And then what are the total legislative asks in each of the out years?
Yeah, so I think on the first question is, I don't know that it could go down any further unless we were to get additional funding for the comprehensive IDD waiver. So if we were to have slots appropriated to raise that point in time number on the IDD waiver, and essentially would, maybe we have a couple hundred additional slots there, then that could potentially reduce the number there. But we are, and we're starting with 500 in the first year, and we hope in the second year to be able to bump that number up to 1,000. The reason we have to titrate it that way is just, network readiness, and, we can't throw everybody onto the waiver right away. So, there's a stair-stepping approach to this. So we're hoping in subsequent years that number will continue to reduce until we get that to
And I guess the
3,500.
reason I asked the question, sometimes it feels like whack-a-mole. We put a little money on something and it goes down, it goes back up. So I was curious to that. And then the second part was the state funding impact on slide 9. I just want to make sure I understand going from state fiscal year 27 into 31. The logic for that is to continually to take 500 more or add 500 slots, right?
Correct.
Okay. Okay, thank you. Thank you, Mr. Chair.
Representative Rivas.
Thank you, Chair. Thanks for the presentation. It's very good. Question is, you mentioned about the people on the waiver now. Some of them may be able to transition to the community support waiver. Do you have any idea what percentage of those could transition over, or is just a ballpark idea?
We did pull some claims data to figure out how many folks on our current IDD waiver are spending less than, I think we looked at just $30,000 to give us a ballpark. And it surprised me. There's a good chunk, I think 30-40% of the folks on the IDD waiver are using less than $30,000 in a year. So that gives us a ballpark. Now, the caveat here is that the new waiver, the community support waiver, is going to have a handful of new services, completely new to the Kansas HCBS system. So there's patterns of behavior that we are still trying to analyze on how that will actually shake out.
Can I ask one more? Sure. So the other thing I understand is that people get on this waiver list and they get on it way in advance of when they know they would need to actually need the waiver. So is that correct? I mean, is it people get on there and it's like years later before they really need it, or so can you break that down a little bit? Like, what's the imminent need, and what's the urgent need, and what's the long-term needs? Has that been charted out at all?
Yeah, there's been some, and I'll let Dr. Evan Dean, he's going to speak to the waiting list study that they did. But yeah, that's something that's always in the back of our minds, is because we do know, folks here that this waiting list is so long, maybe they don't need it right now, but they're still encouraged to get on it. And I mean, we certainly aren't going to discourage anyone from getting on the wait list. But there is an element of needing to forecast who's going to have that imminent need in the near future.
Thank you.
Representative Ruiz.
Thank you, Seth, for the presentation. On slide 8 at the bottom, indicate we're still aiming to apply for the CMS for the support waiver later this year. I thought we already had that. Am I wrong? I thought we already gave legislative approval for the application, a couple of years ago.
Yeah, I think that's maybe an open question on our end. There's some elements with and we can talk about this later this afternoon, I know, as well. But with the conflict-free case management and some of the modernization efforts, and the state being under a corrective action plan, and how if we're making changes over here on the community support waiver that will impact the IDD waiver, there's a little bit of an open question on do we need to get that approved from the legislature to put into the community support waiver with the understanding that it will eventually port over and also impact the IDD waiver.
Is that something that this committee could act on?
I'm not sure.
Yeah, this is exactly why that bill was more of a hindrance. Thank you.
Well, I don't think that's a very big obstacle, quite frankly, to the community support waiver, the LCC approval. But I do want to go back to slide 9 and kind of talk about Representative Bueller's question. So with those figures, though, if we take people off of the main waiver, which is $70,000 a year, and we're only spending $20,000, there's a $50,000 savings for each one of those people that may come off. So I'm just saying it's not like it's going to be 26 million, because if what Seth alluded to is if there's 1,000 people on the comprehensive waiver with 13, 14 services, and they come off of that because they don't need all of those, that's going to be a savings for each one of those of $50,000 a year. So it's a static number is all I'm saying, but we could technically, it's almost a wash as far as what I look at. I believe, and nobody's told me wrong yet, but I think that half the people that come off of that are on our comprehensive wait list right now will come off and do the community support waiver. So there's that savings there. So it's not like it's going to cost us 26 million, because it's, it's moving back and forth, offsetting that expense of $70,000. When I first started looking at the community support waiver, it was $48,000. So it's been way longer than I ever wanted to be, but to get this done. But in a 3-year time frame, basically, it's went up $12,000 a person per year. So if we can offset that to the 20,000, it's just going to continue. It's going to stop that continuation of expenses. But anyway, I didn't mean to steal your thunder, Seth. I'm kind of passionate about this one. Committee, further questions? Okay. Representative Opreza.
Thank you, Mr. Chair. I have a quick question, since I was new to social services budget just this last session. When you say they have a $20,000 budget, are they required to use the entire $20,000? And if not, where does the excess go? Does it just go back in the pot? And then, if anybody has any leftover or not used funds, does that then add to taking someone off the wait list?
Yeah, that's a bit of a complicated answer, with Kansas being a managed care state. But the short answer is no, they're not required to spend the entire $20,000. It really ought to be tied to their, in HCBS, they've got what's called a person-centered service plan, which identifies the needs, scope, duration, goals that a person has for how they want to utilize their services and leverage those services to live their best life. So it really is supposed to be tied back to that. So we might have folks who come onto the community support waiver and spend maybe just need a little bit of respite in a year and spend maybe $5,000, right? Whereas other folks are going to get onto the waiver and need every cent of that $20,000 budget. So there's a little bit of an unknown, with it being a new waiver like this and having a capped waiver for the department. It's a little bit of an uncharted territory, and knowing how folks' behavior is going to be impacted when they get onto the waiver. So those first couple of years are going to be really critical for us on analyzing how that really and what the impacts are to people's services, and if they're actually getting everything that they need with that amount.
Thank you.
Senator Holshire.
Thank you, Mr. Chair. Thank you, Seth, for the information. I will say my question might be more appropriate for the afternoon, but I may have to step out, and so I wanted to go ahead and get this to you, and hopefully I can follow up if need be. I know there's been a push to get rid of the targeted case management due to concerns by the federal level regarding conflict of interest. However, I've heard from some families, IDD parents and families, that they may not feel that conflict of interest exists. So my question is, does the new CMS administration have a problem with targeted case management systems?
We've not gotten any indication that they have any issue with targeted case management. It really is about that federal conflict of interest provision in the rule. itself. So, we certainly, as an agency, recognize and have heard, over and over again how important and critical that target case manager is for folks on the waiver and even those on the wait list who happen to have a TCM. So we certainly, would back keeping it for the IDD waiver and really strengthening that role.
Okay, thank you so much.
Senator, I think later on today, we'll probably have some more answers for your question.
Yes, thank you,
Okay.
appreciate it.
Committee, further questions? Seth, thank you.
Thank you.
We'll see you later. Okay, moving on. Janine? WebEx, okay. I'm not even going to try to butcher the last name there on that, so. Janine, are you there? Okay. Can you let us know when she comes on? Next, Dr. Dean. Yeah. This will, welcome to committee, Doctor. Thank you so much. He knows so much about this wait list and the study and all that kind of stuff. It'll answer a lot of questions here, I think, with him. So thank you very much. Welcome to committee.
Thank you, Chair Carpenter, and thanks for the confidence and the boost in the information that I'm going to share. And thanks, committee, for giving me the time to talk with you all. I'll say, too, I'm going to be joined by Kendra Cryer from OCCK, who's been a part of some of our capacity building work on employment. I don't know if she's online yet, because I know we're a bit ahead of schedule, so just wanted to put that out there for, but I'll try to talk longer, so give her a chance to get on, so. Not really. But thank you all. So my name's Evan Dean. I'm an associate director at the Kansas University Center on Developmental Disabilities. And we contracted with KDADS to do a study of both the waiting list for physical disabilities and intellectual and developmental disability services. And I'll give a little more history about that, because I think some of you probably haven't heard about that. But so this study was done as a partnership with several entities at KU, including us at the KU Center on Disabilities, and also Jean Hall and Noel Kurth at the Institute for Health and Disability Policy Studies, Carrie Wendell Hummel at the Center for Research in Aging and Disability Options, and Shay Tanis at the State of the States for Intellectual and Developmental Disabilities. So these are all centers at KU, and all really have a national reputation for their research on disability policy and practices. So we had assembled a great team, and we're really excited to work with KDADS on this study. Just a quick little bit about us as the Center on Disabilities. We are what is called the University Center for Excellence on Developmental Disabilities. So we are. So we're part of a network of 67 UCEDs from across the U.S. And the territories that work towards a shared vision for people with disabilities to fully participate in their communities. We are authorized under the Developmental Disabilities Assistance and Bill of Rights Act of 2000. Or the DD Act, as it's called, and we work closely with what we call our DD Act partners that were also authorized under that bill, and that's the Protection and Advocacy Organization, which in Kansas is the Disability Rights Center, and also the Kansas Council on Developmental Disabilities. So each of these organizations have different functions. At the university, our core functions are research, community engagement, education and training and information dissemination or sharing information with the public. This project in particular is exciting because it crosses over all of those services. We were able to like really engage the community in the research we were doing. Can we go back one slide? Oh, sorry. I must have put them in the wrong order, so you can go ahead. So I wanted to give just a little bit of context because we conducted this study beginning in October of 2022 and completed it at the end of 2024. So things have changed. The landscape has changed a little bit, so just wanted to provide a little context. As Seth talked about, the Kansas is developing the community supports waiver right now, and used actually data from this study to develop the services and for that waiver. And then KDADS is also doing a lot of work focusing on the unbundling of services, including conflict-free case management. And updating service definitions and rates. So I think all of this is, building capacity for serving people on the waiting list. Some other things that are also happening, CMS issued their ensuring access to Medicaid services final rule that's going to require states to report on waiting lists. So I think there's a need there, and part of our recommendations is around data systems to track the waiting list and people waiting for services. And then also just want to point out that KDADS has been doing work too, also to advance both employment and services for technology. And this will play into some of the data that I'll show a little bit, but starting to build some of that capacity that we're going to need to really serve people on the community's support waiver. And then also doing work to build capacity around the direct support workforce. So a lot of this was done through ARPA dollars, and I think these were really strategic investments to kind of build the capacity for what we're going to need going forward in the state. Just a quick timeline of our study. As I said, we began the study in October of 2022, right about the time as that special committee on service modernization was happening. And so as people began to talk about the community supports waiver, this study, studying the waiting list, was an opportunity to really gather information to inform the work of that waiver. At that time, there were about 4,500 people on the waiting list for intellectual and developmental disability services. By January 2024, which is when we got kind of the final round of administrative data that we analyzed, the waiting list for people with intellectual and developmental disabilities was 5,240. And about 2,200 on the physical disabilities waiver. Since then, the legislature's done a lot of work to increase the funding and the number of slots. So those numbers have gone down and they've capped the services. And I had the numbers here on the as of July. I think the numbers that I saw on KDAD's website were the waiting list was at 48, a little over 4,800, and I think that's changed as Seth's information was more current. So that number has changed now also. So now I'll jump into the project that we did. I know some of you have heard this background before, but for newer members, wanted to provide just a little bit of an overview of the project. We also submitted our final report as testimony. So again, another page turner for y'all to really dive into and enjoy. But just a quick overview. We were doing mainly two things on this study. One was analyzing administrative data that KDADs have had regarding people on the waiting list. So this is both numbers, some demographic information, information on crisis exceptions, and also Medicaid claims data of people on the waiting list. And then the other thing that we did was developed a survey to better understand the needed supports and the experiences of people on the waiting list. So we can go to the next one. So for that first aim around analyzing the existing data, our attempt was to both understand the overall makeup of people on the waiting lists, and also to really dive in and understand the service needs and crisis exceptions of people. And that both informed the survey, but also provided a lot of insight to the services that people on the community supports waiver were going to need. So we can go on to the next one. So this data comes from January 2024, so it's obviously changed a little bit, but I think the core message here still applies. So overall at that time, most of the people on the waiting list were under the age of 20. So about 3,042. The other thing we looked at was of those people that are under 20, who was eligible for who was on Medicaid. And so that was about 2,036 people. So this is a big group of people that are under 22 who are receiving Medicaid, and therefore would qualify for early periodic screening, diagnosis, and treatment services, which they would be eligible for because they meet the qualifications for based on their Medicaid and their age. So these are services that are health and medical based. So it's an avenue for people that are on the waiting list to be receiving some services and supports. So it's a way to, when we think about how do we eliminate, and to your comment earlier about services that people joining the waiting list early. This is a way, people are joining because they're going to need services, but at this younger age, there are other options for services that they could be utilizing, and EPSDT is one of those. So we can go on to the next one. And then on the physical disabilities waiver, the vast majority of people are age 21 to 64. Most of my data, though, is going to be focused on people with intellectual and developmental disabilities for this special committee. We looked into crisis exceptions, and so this information came from a spreadsheet that the IDD program manager kept to track crisis exceptions and priority populations. So you can see, and so we went through and coded all of this information to really kind of understand, what were the situations that were leading to the need of a crisis exception. Which would then, if someone has qualifies for a crisis exception, they can enter into services sooner. And priority populations are groups that, depending on that population, would move to the front of the waiting list. So caregiver needs were something that the majority of people who were granted crisis exceptions or priority populations needed, and that included things like aging caregivers, death of a caregivers, family members that needed to work, and those kinds of things. The other highest categories were related to significant behavioral support needs, abuse, neglect, and exploitation, and criminal justice involvement. So a lot of need there for behavioral and emotional supports. And services. The other thing I'll say about this is that, that people were coded into more than one of these categories because people's lives are complex. So, a lot of times, as an example, if the child had a significant behavioral or support need, the caregivers may also be needing needs also in terms of just not being able to support the child anymore, needing more respite or things like that. So lots of times some of these were coded together. So we can go on to the next slide. And so these are the priority or the crisis exceptions from the PD waiver. And because of how the data for the PD waiver was tracked, this data obviously looks very different. This was tracked more based on the policy for crisis exceptions for PD, the biggest one being an imminent risk of nursing facility and placement. One of the things I do just kind of want to underscore as you look at the difference between there, that this information was gathered very differently, really based on the program managers, how they went about developing it. So this will kind of play into some of the recommendations we have around a data system to really track this, so that that it's easy to extract this data and understand it. So we can go on to the next one. So the second aim here was around a survey to really understand the needed supports. And we're gonna, I'm gonna share some results, and all of this is in the final report also. I'll just say that this was a big project to develop this survey, and we worked very closely with the Self-Advocacy Coalition of Kansas to be sure that the items we were developing and the survey overall was accessible for people with intellectual and developmental disabilities. And we built in a lot of supports for people to be able to take the survey. We also worked very closely with the CDDOs and the Centers for Independent Living in this state to help recruit and get the word out, because they're the organizations that are closest to people on the waiting list, and they were a huge support, and it was great working with them to really boost the numbers of people that completed the survey. We can go on to the next one. So through our conversations with SAC and with families and providers, one of the things that we learned is that what we originally proposed was creating this survey for people with intellectual and developmental disabilities and physical disabilities that are on the waiver to complete this survey. But through our conversations with SAC and families and others, and also just our analysis of the crisis exceptions data, we realized we also needed to understand families' experiences and information for them. So we ended up creating two surveys, one for people on the waiting list and one for their caregivers. I should say, too, on that previous slide, we didn't just create these, but we used tools that were in the field, like the National Core Indicators, which is used across the country to develop outcome information on people with intellectual and developmental disabilities. The Supports Intensity Scale, we use that as a model for developing some of the surveys to understand support need, because it's a evidence-based, strengths-based assessment on support needs. And for the caregiver survey, we adapted a survey that was developed by the Office of the Assistant Secretary for Planning and Evaluation in the Department of Health and Human Services. They had developed a survey for caregivers supporting people with disabilities in the service system. So, so we were, as much as we could, we were using tools that had been existing and tested. So I'll share just a few slides here related to some of the data we found. So on this one, I want, sorry, that's hard to read on the slide, but so the first 4 bars on this chart are, the first one is, these are living preferences of people on the waiting list. Because we really kind of wanted to get a sense of what services and supports are going to be needed as we both bring more people off the waiting list and develop the community supports waiver. So as we go on the left, the first one is people's preference to live alone. The second one is with a parent relative. The third one is with a partner or spouse or their children. And the third one is a shared house or apartment with one or a few roommates. So these are all housing options, in the community like anybody else would be using when they're starting to live on their own. And this was it makes up about 82% of our sample saying that this is where they wanted to live. The next bar is at 4.9%, and that's living in a building or home with other people with disabilities. So like a group home that are traditionally used in the service system. So I think this is really interesting data just to show that our traditional models of agency-supported housing and groups home are not places that people are saying that they want to live. They want to be living in apartments with families and other places in the community. So I think that has implications for the community supports waiver too, in terms of flexibility, in terms of how people can use those funds for living supports. So this slide is about the frequency of supports that are needed for people on the waiting list. And I think it's important to note that we were asking about what supports do you need and not what supports are you getting. And so I'll walk through this a little bit. The blue line, which is highest on most of the areas, is looking at are people saying that they need daily support. And the yellow line right next to that is hourly support. So I think one of the things that we learned from this, and I should say the different areas of bars are all different places and domains where people might need services. So home, community, learning, work, health, and social supports. So I think one of the things that we learned through this, we were a bit surprised that the supports that people were needing were higher than what we thought, with many more kind of saying that they needed daily support than we were anticipating. So I think there's implications there for the community supports waiver. And I know we're kind of capped at that $20,000 range, but I think we'll need to kind of watch that closely and be sure that people's needs are being met when they come into the community supports waiver. So we can go on to the next slide. So this is the types of support that are needed by people on the waiting list. And again, broken down into those same areas of life. But so kind of walk through this a little bit. The blue line on the far left is technology support. So I think that's a funded service under the community support waiver. But also I think it's an area where KDADS has been making some investments on technology first and building capacity for being able to offer services related to technology. The yellow line is durable medical equipment, and this number is low, but this is something that's critical for people with significant health and medical needs. So I don't want to dismiss it because it's a low percentage. It's something that for people that need that really need it. And then so the black line then is family and friends, and the teal line next to it are paid supports. So these are the supports of other people that people need, which can get expensive. And I think that the other thing that, you know, because people talk about paid supports and families and friends, I think with the community support waiver, one thing to keep in mind is that we need to be sure that there is flexibility in how people, who people can pay for the services that they need, and how they can do that. And so this was part of the caregiver survey, and we were asking caregivers what resources they currently use to support the person that they support. And so here, you know, again, on the left, family and friends were both highly endorsed. Community resources were also being used, and school-based services is another one. So that's not totally surprising. 56% of our respondents were school-aged. So I think that's probably why there was a high number there on the school-based services. Another thing to note on the end is about 28% were using emergency services for different things. And so this slide is just talking about what services would help. So really wanted to get a sense, especially as we were developing the community support waiver, what services that caregivers thought would be needed. In this, I'll call your attention to the black line, which is don't have support and would like to have support, and the teal line, which is have support but need more support. And so some of the big areas that I'll just point out, the third grouping is about in-home respite or temporary support out of the home. And the next one is in-home services, like a personal care attendant coming into the home. So those were the two that most people were saying they didn't have and really needed. The next one over is temporary out-of-home respite care. So things that are covered on the community support waiver. So it's good that we're kind of tracking there with people's needs. So as I said, one of the other things we did, and just this is my last data slide, so we'll talk about recommendations here in just a second. We also studied Medicaid claims to look at the health of people on the waiting list. And our findings suggest that people on the waiting list are more at risk for greater health problems and are also getting sicker while they're on the waiting list. The survey we did also, over 90% of people on the physical disabilities waiting list said that their health was either fair or poor. And 54% of people on the IDD waiting list said the same thing. So I think this is important, in particularly, well, I mean, in terms of people's health, but also in terms of cost. I think it means that people are entering services when they're sicker, and then using more supports, more services when they come in. So I think, you know, something like some more preventative services while people are on the waiting list could be a way to reduce overall costs on that.
Okay, doctor.
Yeah.
I know you have an appointment at 10 o'clock.
Yes.
So I don't want to make you late for that appointment. And I hate to interrupt, but I know you need to get there. So committee, if we could just stop right here, and he'll come back. And we also have the Janine online now. So if we could stop, I appreciate you filling in for her, but I know you have a 10 o'clock. So
Sure.
If you could just come back to where you started, and I know the committee has a lot of questions too, so would that be all right?
Yeah, that'd be awesome. Yeah.
Okay.
We're just jumping into recommendations, so that'll
All
be
right,
perfect.
very good.
Great. Thank
All
you.
right, thank you.
Thanks for watching the time.
Sorry about the confusion, but I know where you need to be.
Yeah, I appreciate it.
Okay, Janine, are you online?
Hi, can you hear me okay?
We can. Good morning and welcome to committee.
Morning. Thank you so much for having me. Will you be bringing up the slides? I just don't see them right now, so I apologize. But as long as you can see them, that's all that I need.
He's looking.
Okay, thank you.
There you go.
Thank you so much. I really appreciate the special committee of the Kansas Legislature asking me to come back this year to talk a little bit about the CMS regulations and conflict-free case management. Next slide, please. Today, I'm going to be pretty much speaking chapter and verse for the conflict-free case management portions of the HCBS regulations. I will not be talking about the settings portion, but I am focusing on conflict-free case management. Next slide, please. I want to start with the basics and where this is rooted in regulation. CMS published these final regulations pertaining to home and community-based services on January 16th, back in 2014. The rule became effective on March 17th of 2014, and the rules establish new standards for what constitutes home and community-based services and includes these new requirements around two things: person-centered planning, what is in a plan and what it should be part of the process, and conflict-free case management as well. The case management and person-centered plan provisions were in force as the effective date of the final rule, which was that March 17th. Many states, including Kansas, are going through completing corrective action plans to achieve compliance with the regulations and working with the Centers for Medicare and Medicaid Services, CMS, who have been a great partner for states to help them work through the structures and processes needed to be conflict-free and meet the requirements. The new regulations require separation of direct service provision and case management or development of the person-centered plan. While the regulations do not give a specific conflict of interest definition, so you will see me quote some of the legal dictionaries, they indicate in the regulations that there are relationships and there are system structures that constitute conflict of interest, and we will get into some of those. Next slide, please. So the real center of the conflict of interest protection in the HCBS rule is to separate case management with person-centered planning development and the service delivery, the delivering of service functions. The conflict occurs not just if the case manager, if they're a provider, but if the entity has an interest in a provider or if they are employed by a provider of services. Next slide, please. These are some of the citations when I talked about doing chapter and verse from the regulations. 42 CFR 441.301 states that providers of HCBS for the individual or those who have an interest in or are employed by a provider for HCBS for the individual must not provide case management or develop the person-centered service plan, except, and I'll talk about this, when the state demonstrates that the only willing and qualified entity to provide case management and or develop that person-centered service plan in maybe a geographical area is the person that is the entity that also provides HCBS. And I'm going to come back to specificity around that only willing and qualified provider in just a bit. The rules also include strategies, which I'll go over, for solving any conflict or disagreement within the process. We call those safeguards, including having clear conflict of interest guidelines for all planning with participants. So we'll get into those in just a bit. Next slide, please. So there are federal requirements to prevent and mitigate conflict of interest that are seen under Kansas operates 1915C HCBS, and these citations are here for you. I already mentioned the first one that requires providers of HCBS for the person not to provide case management and develop the plan. 42 CFR 431 also requires that the state Medicaid agency is responsible for all eligibility determinations, and eligibility determinations can only be delegated to another governmental agency with state Medicaid agency oversight. It further states that case management activities must be independent of service provision, as I noted, and that an entity, agency, or organization cannot provide direct service and case management activities to the same person, except in those unique circumstances where we will talk about the only willing and qualified provider. Next slide, please. The 1915I is a state plan HCBS, which is different from a 1915C. And the major difference between the two, just for your information, is that in a 1915C, the person has to meet ICF IDD level of care or a hospital level of care. And in a 1915C, you can also limit access by each year identifying your unduplicated participants. In a 1915I state plan, your state plan HCBS, anybody who meets it's called needs-based criteria, has access to that service. You cannot have waiting lists for state plan services. So in the state plan area of this rule, federal regulations require that the state Medicaid agency, again, is responsible for eligibility determinations, as I noted for a 1915C. And it goes a bit further in the conflict of interest provisions. So in that regulation, it states that under no circumstances can a direct service provider determine eligibility. This applies to, as we know, there are financial eligibility requirements and there are service eligibility requirements. And also a step further in a state plan, HCBS, individuals or entities that evaluate eligibility or conduct the independent evaluation of eligibility for state plan, home and community-based services, who are responsible for the assessment for the person, or who are responsible for the development of the service plan. There are certain other provisions, can't be related by blood or marriage to the person or to any paid caregiver of the person, be financially responsible for the person, be employed to make financial or health-related decisions for the person, or have a financial interest in any entity paid to provide support to the individual. So that 1915I state plan HCBS goes a little bit further in the conflict of interest requirements than the 1915C. Next slide, please. So I talked before about, how do we define this conflict of interest? And more so, after we define it, how and why does it matter at all? Next slide, please. So this is by no means in the regulations, but we looked at Black's Law Dictionary to see what a definition of conflict of interest would be. And it's defined as a real or seeming incompatibility between one's private interests and one's public or fiduciary duties. Just a basic definition, and I like to use that to set the framework for the regulations. Next slide, please. So if we delve a little deeper in this, and these are all just, I want to say, potentials. Not saying that this is happening across the country, but what is a private interest? What would be considered a private interest? So Private interests are those natural to any business, right? Any business interested in its own survival, its own competitive environment. So, for example, a provider may have an interest in maximizing their revenue by increasing the number of people they support and the amount that they are paid for services. Private interest may be that you are wanting to, minimize your costs, minimizing the costs associating with the people that you're supporting. Even though you're fully serving them, you're looking at, cost is always a factor. You're maybe improving your competitive position related to others who do similar services. So, you might be promoting awareness to your services. This is just a general definition and some examples of what a private interest could be considered as. Next slide, please. I mentioned a fiduciary relationship. So financial conflict of interest could potentially create incentives for either maybe over or underutilization of services. So case managers, if they are part of an organization that's providing services and doing case management, they may feel pressure to steer the person to their own individual organization. Again, just an example, not saying that this is happening across the country, but it has the potential for that steering. Or maybe retaining the individual rather than promoting choice of all of those willing and qualified providers of services. So we see that since conflict of interest, you can see the relation that it may have the potential to compromise choice or quality in accounting or any of those things could. And conflict of interest is definitely, from a CMS perspective, essential to really doing person-centered planning for each person based on their unique needs. Next slide, please. So applying these concepts to service planning when the same entity both assists the person to gain access to services and provide services to that person, there lies the possibility for the potential for a conflict of interest. Conflicts may occur in areas, as I noted, such as honoring free choice of providers, overseeing quality and outcomes, and I'll talk about that in a bit, and maybe open the possibility of decision-making based on maybe some financial concerns. Next slide, please. Oftentimes, when we talk about conflict of interest, choice always comes up, right? And choice is a key tenet of person-centered planning and a key requirement for Medicaid. It's full freedom of choice of the types of services and individual providers. That person has informed choice. Case managers have the responsibility to support an informed choice. Medicaid requires it about the types of supports and services and individual providers. And in conflicted situations, as I noted, there may be this unconscious effort to steer people, and that may affect choice. Next slide. One of the key tenets of case management is monitoring of supports and services. If you have a system that may have the case manager performing quality oversight activities, if they are working for the same agency that provides services to someone, that puts them in a little bit of a precarious situation. They're really having to do this sort of what we'll deem as self-policing because they are monitoring the services that their agency is providing. This puts them in a position of assessing either maybe the performance of a coworker or a colleague within the same agency. Case managers really would have to evaluate the performance of coworkers, supervisors, with the very organization that employs them. So that's just a little bit of what would happen potentially in the monitoring, and what position that would put a case manager. Next slide, please. So why do we think this sort of monitoring your own organization does not work? The first thing is it may negatively have the case manager, as I noted, assessing the performance of their colleagues in the same organization. Case managers do not have the position most oftentimes. I started in this field as one, or feel like they have the degree of authority within an organization to require changes of the other staff if they're doing their monitoring. On a personal level, case managers may find themselves reluctant to criticize or provide feedback to other workers. So these are just examples of why this would put a case manager in a very difficult position. And again, this self-monitoring may lead to focus on the convenience of the service provider rather than being person-centered. These are all directions and reasons why I think CMS really, the conflict of interest provisions have been in that technical guide for 1915C waivers for a very long time. But I think the focus here was making sure that the regulations were codified so that states would come into compliance with those regulations. Next slide, please. So what happens if there is a conflict? Next slide, please. So I talked about this provision of only willing and qualified provider. So in a webinar that you can find on the CMS website, it was titled Conflict of Interest. There's a part 1 and there's a part 2. And in this part 2, CMS indicated that the basis for using this option of only willing and qualified provider could be, and you'll see this in some of the examples that I provide later, a rural or frontier area that naturally limits the pool of available providers. That might be one of the reasons that it's approved. There may be cultural considerations requiring expertise that limits the provider pool. You need to have some providers with this expertise to support any cultural considerations. Or there could be linguistic considerations that may require different competencies of case managers for them to effectively communicate with and support certain populations. So this is by no means all of the examples, but this is what CMS noted in that webinar series. CMS also noted in that series that the state should provide supporting documentation for the request, such as data showing the basis if they're looking for the rural or frontier designation, or any information for linguistic or cultural competence. So they want to see information and data that demonstrates why a state would be going for this only willing and qualified provision. Next slide, please. Continuing on, this is just a slide that has those 3 things on it for you, and it also has the link to that webinar part 2 that I noted. So I'm just going to go on to the next slide. Next slide, please. So if you are a state that is going for the only willing and qualified exemption, CMS also notes that in certain circumstances, they may require the states to develop what they're saying are firewall policies. And those are just protections for the person. And that being said, one of them is separating staff that perform assessments and develop the person-centered service plans from those that provide any of the services in the plan. So if you are going for the only willing and qualified provider, CMS also would like that baseline safeguard that if you are providing services, you're not developing the person-centered plan for that person, same person, okay? So that's like a level that they will allow. They also may want you to have meaningful and accessible procedures. They always want you to have this, I should say, for individuals and representatives who may want to appeal to the state for only having this only willing and qualified provider option. Next slide, please. So some other examples of some of the safeguards that we have seen are, always making sure that individuals that are being supported, you disclose to them and assure them that they are supported in exercising their right to free choice of providers and are really provided information about the full range of waiver services, not just the services that are furnished by that entity that is responsible for the person-centered service plan development and was approved as the only willing and qualified provider in that geographic area. Also have to make sure that there is an opportunity for the participant to dispute the state's assertion that there is not another entity or an individual that is not the individual's provider to develop the plan through a clear and accessible alternative dispute resolution process. And as always, that person can always choose maybe another case manager in a neighboring county. And I know from what I understand that the state of Kansas is really working hard to make sure that there's as little disruption as possible for individuals being supported. Next slide, please. Continuing on, that there's direct oversight of this process and periodic evaluation by the state. So once you get this only willing and qualified provider exemption, it's not you get it and you're done. You really have to have oversight and periodic evaluation, because if another provider of case management wants to move into that geographical location, then there is not only one willing and qualified provider. So that provision would most likely go away. They have to watch the states for restricting the entity that develops the person-centered service plan, and they want this to happen from providing services without that direct approval from the state. So the state puts in for the only willing and qualified provider exemption, and then that provider would receive approval from the state. They cannot do that until they have that approval. And then requiring that agency that develops a person-centered service plan to administratively separate out the plan development functions from the service provider functions, not for that same person, as I noted before. Next slide, please. And I just want to say that there are states across the country that these are minimum criteria. So any state, just like CMS gives states a lot of leverage in their waiver, may impose any additional conflict of interest requirements that they see as appropriate. CMS regulations are the baseline that states have to meet, but they also can impose additional requirements if they so saw fit. So as you are probably all aware, in Kansas and many other states that I will review, CMS has been actively engaging in conversations with states about how they will meet these requirements. Many states were on a corrective action plan and working through that to meet the regulations. Next slide, please. So what about managed care entities? We know you have managed care entities in Kansas. So managed care entities can provide case management and perform assessments, but if the managed care entity, if they do operate direct services and provide case management, they must demonstrate to CMS that they are the only willing and qualified case manager. CMS applies the regulation to the 1115 demonstrations. If the managed care entity contracts but doesn't operate or own direct care services, it's not considered a conflict of interest for the managed care entity to perform case management. Managed care entities cannot determine eligibility for programs. I mentioned to you that eligibility determinations have to be done by the governmental agency. So if a managed care entity performs assessments that result in scores that determine level of care, the state has to perform some representative sampling to ensure the accuracy of level of care. And this is definitely a requirement of Medicaid programs. Appeals processes must be in place to avoid decreases in support. And that must include entities outside of the managed care entity who support individuals. Every state usually has its own appeals process for individuals. And managed care entities must provide freedom of choice within their networks. That is the all willing and qualified providers. And it's very acceptable for any person to leave service and pick another provider at any time. Next slide, please. So how are other states? One of the requests that I had is to tell you a little bit about how other states are addressing conflict of interest. Next slide, please. I had a few examples in last year's presentation that are here, but I did identify 2 new states that I've been working with. So I'll go over those in just a second. So NASD's did a survey a couple years back wanting to know how case management is funded across the states. So we did a survey in 2018 of state systems supporting individuals with developmental and intellectual disabilities. We had 45 state respondents. And from that survey at that time, 34 states, including the District of Columbia, reported that all of our systems are fully compliant with the conflict of interest regulation. On the other hand, 21 states indicated that they have had to make changes to comply with the conflict of interest rules. And 11 of those states, some of which I will speak of, they were in the process of a full-fledged system redesign to eliminate conflict and on a corrective action plan with CMS. Next slide, please. So what was in those corrective action plans? Pretty much states were focusing on support plan development versus implementation of the plan through that provider. They were focusing on monitoring requirements for case managers that they do of a service provider. And they were also handling transition from what is their current system to do they have then a complaint system in place for anyone who has a problem with the way that their services or case management is implemented. Next slide, please. So one of the newer states that's also an 1115 demonstration, Vermont is a state that has recently came into compliance. They have an 1115 demonstration called the Global Commitment to Health Waiver. And those 1115 demonstrations are kind of like the hat on top of the different waiver programs. So Vermont operates 5 programs under 5 waiver programs, 1915Cs. under this demonstration that were affected based on the conflict of interest provisions of HCBS rule. CMS notified the state in 2021 that they must come into compliance with HCBS conflict of interest regulations. There was a determination that the desired assessor and case management qualifications and roles and responsibilities be separate from direct service providers. Vermont developed, much like many other states, a multi-year plan to come in full compliance with the requirements to separate eligibility, assessment, and case management from the direct provision of service. Vermont's multi-year plan started with a lot, just like every other state, a lot of stakeholder engagement and a plan that really mapped out the key internal and external stakeholders and when and how each of those would be involved and what their roles and responsibilities would be in the new structure. They reviewed available data regarding eligibility and assessment, person-centered plan development, and who was implementing, HCBS, delivery of services and case management. They also developed reimbursement methodologies that were different and financial modeling. So they had to look at how existing reimbursement methodologies and rates were developed because they are now separating that out. So they had to do it based on the new scope of work. They also had to update statute, policy, regulations, manuals, really identifying all of those changes that are necessary across the system. Lastly, they developed some very intense implementation planning. And what that means is sometimes you really have to develop process flows where you see visually who's doing eligibility, who's doing assessments and reassessments every year, who is doing training for the conflict-free case management entities. Those individuals are doing service coordination, and then who are their providers? So they did a map of the current system into looking at the data and understanding who was providing both case management and direct care and direct services and what they wanted to do moving forward. Next slide, please. Another state that is going through the process pretty heavily and also has an 1115 demonstration is Rhode Island. In Rhode Island, approximately, I think 2,500 or maybe 25% of Rhode Island's Medicaid HCBS participants who were under the HCBS final rule they noted in conflict and receiving person-centered planning and case management and direct service from the same providers. Participants were receiving case management again then, that is not conflict-free. That same entity was providing eligibility assessments and enrollment and case management and direct services to a participant. So they had to work through that entanglement. They also noticed then, because all of this was happening at once, that their visual into quality management and the delivery of case management wasn't consistent across all of those vendors across the state. So they really developed a quality management plan then once they stood up the conflict-free case management entities in the state. There were 3 goals to their service design. One was to improve Medicaid HCBS participant access. 2 was to create an infrastructure to deliver high-quality case management that complied with the federal and state regulations. The restructure led to new certified conflict-free case management entities that are not delivering any services. The cap was approved in February of 2023, and they were slotted with full compliance December of last year. But I do know that they're still working through some of their implementation efforts. Next slide, please. South Dakota was another state that went through conflict-free case management provisions. Their case management and multiple direct services were delivered to individuals with developmental disabilities by 19 what they called community support providers. There was concern about choice and conflict of interest in person-centered planning. So they were having discussions way before the HCBS settings rule even came out. The HCBS rules really helped South Dakota propel into the process when they came out. They already were having meetings with stakeholders and engaging in discussions with case managers and talking through parameters. Individuals were not unhappy in South Dakota, but the implementation of case management did not comport with the HCBS rules. So through that transparent process with their stakeholder engagement, they had to shift case management from those 19 community support providers that were really created in probably, they said, the 1970s to support people coming out of institutions. And they were also providing case management in multiple services. Next slide, please. So what does South Dakota's new system look like today? They shifted to dedicated case management agencies, and they have 2 regional and 2 statewide case management providers, smaller state, as we all know. Through that inclusive and transparent process, 100% of the people that are being supported in South Dakota chose a conflict-free case manager during their open enrollment period. Despite South Dakota being a frontier state in general, they didn't use the rural exception. They were able to find providers with either regional or statewide capacity in their state. It took them 2 years to achieve system compliance. And when we talked to South Dakota, they said that they really attribute their success to establishing their aggressive timeline and having years and years of what they called real stakeholder engagement with all of the people that were affected by this change in South Dakota. Really did an intentional effort and had many, many, many stakeholder sessions. Next slide, please. Another state, very big frontier state, is Alaska. And Alaska is very big. And access to services is really complicated in Alaska by not only the size of the state, but the geography of the state. So when they were talking about conflict of interest, they entailed major changes to providers and the people being served. And they wanted their design, just like every state, to be as attentive to any disruption. So they wanted to limit that disruption, keep people informed along the way, every step of the way. And this was a cross-disability effort. So they had their IDD agency and their aging and disability agency, and both of those populations used a different model of case management. So they needed to really think about the balance between creating access and assuring quality in Alaska. And I'll talk about it, they did a flexible approach, tried not to be too prescriptive, to allow for different models of case management, including independent case managers, as well as agency-based case managers, but both were conflict-free. Next slide, please. So what does their new system look like in Alaska? The overall new system structures separated case management from direct services. They have the independent case manager, which they call care coordinators, and they also have agency-based care coordinators. They have new rules and regulations for independent care coordinators because before, some of these individuals were embedded in those agencies that were providing services. So they came out of the agencies as certified independent case managers. They have to meet the standards and business requirements. And they found in Alaska that allowing independent care coordination required additional state structure and oversight and monitoring, right? Because that increases the provider pool for sure. So they hold monthly support coordination, care management, case management network meetings. They also have meetings about approving and authorizing plans from the state. So they really set up a structure where they are in close contact with conflict-free case managers. Next slide, please. Alaska, being such a frontier state, was also granted the only willing and provider exception. And this was due primarily to the rural nature of many of the areas in specific low population census areas. So by low population census areas, the number of conflict-free case managers that they had couldn't meet the capacity for the number of individuals that they had to support in the census area. And the number of those conflict-free case managers certified could not meet the capacity to serve recipients by waiver type. So they received approval, but I mentioned earlier and gave you some examples of safeguards. Their safeguards were that provider entities must administratively separate, again, that direct care and case management activities, including separating the oversight. Their case managers must take required training on person-centered planning and identifying conflict of interest. They must assure that they do not have a conflict of interest and do not provide any direct services to anyone, the same person. And all plans of care, which are their person-centered plans, were reviewed and approved by their state personnel. And individuals were always informed of their rights, including how they're able to file a grievance. Next slide, please. Colorado is another state. So services and case management in Colorado were in place prior to whenever they, put in for waivers and Medicaid funding. They have been in place, the community-centered boards in Colorado, for a very, very, very long time, way before these regulations ever came into play. So these community-centered boards that are in Colorado, they didn't just provide case management. They were the go-to place for everything IDD. They were an organized healthcare delivery system, which means that they are a provider of service who can also pay other providers of service, so they don't have to contract with the state. And they also were providing state-funded programs. Next slide, please. So Colorado worked really hard to separate case management from direct service provision. Individuals were afforded choice in case management agency and their direct services. The real or perceived conflict of interest doesn't exist. They did get a rural exception for certain areas of Colorado. The way in which case management is delivered and reimbursed was redesigned. They also allowed individuals case management, and they also individuals can receive the level of case management that they need, and case management is reimbursed according to the individual needs. They may have some tiered rates there, and it also resulted in an increase in provider capacity once they separated out some of those functions. Next slide, please. So in closing, I want to say that CMS is still very serious about conflict of interest. Every state is serious about protecting the people that they support's choice. And this conflict-free provisions was an opportunity for many states who reform their systems. States have that opportunity to create dedicated standalone organizations whose only mission is case management. And I noted some examples of states that have done that. There are also states who asked for the only willing and qualified exemption in certain areas. And the exemption is really that. And CMS seems to be holding firm in their expectations of approvals of those exemptions. So I want to take this opportunity to thank you again for having me to talk about conflict-free case management and the HCBS regulations. And I would welcome any comments or questions before my time is up.
Janine, thank you so much for that. I know there will be a ton of questions from the committee. I just want to take this opportunity to, I should have talked about this when we opened the meeting, but committee, that is why we are here, is to address this conflict-free. We have roughly 30% of our folks are in conflict, not conflict-free. 70% of our folks are in conflict-free case management. So regardless of the fact that it was supposed to happen in 2014, it's going to happen now. We have no choice, unless we want to cough up, let me see what I've got here. When it comes to the ID and DD program, so our portion in 2025 is 245 million. All funds was $640 million. So CMS has a pretty big stick right there for us to get our act together. And unless we want to cough up another $300 million for this program. So it will happen. We just have got it done. We've just got to get it done, and that simple. It's been kicked down the road too long, and we need to get this done, period. So with that, committee questions. Representative Bueller.
Thank you, Mr. Chair. Janine, is she still there?
Yes, hi.
So a question I did, while you were going through your presentation, I was doing some quick Googling on South Dakota. Population 924,000, so about a third the size of the state of Kansas, with roughly 4,000 people who have developmental disabilities. I go back into your presentation, and one of your bullets is South Dakota shifted to dedicated case management agencies and has 2 regional and 2 statewide case management providers. Are those state agencies or are those private?
I think they are private, but I will definitely double check that and get back to you.
Okay, yeah, so for me, that would be helpful. Because what I wouldn't want to see is the creation of another state agency to do case management. So if you could do that, I'd appreciate it. Thank you very much.
Sure. And I just want to say too that if they do have case management at the state level, like for instance, Rhode Island did and does, who are reviewing and approving plans, they didn't develop another state agency at the state. That's within the IDD structure. They just have state case management, and they may be paying for that through administrative dollars for the efficiency and operation of the program.
Okay, that's helpful. Thank you. Thank you, Mr. Chair.
Sure.
Committee, further questions? Representative Ruiz.
Janine, thank you again for the really very thorough presentation. My question is, I know we have all the examples here of these other states, but, and in speaking with many families who are really concerned about having to make changes to their services because they're, having, they're within that, they have conflict. So they're having, make some changes, and there's a lot of consternation about that. And so, and it's totally understandable. But I also know that this is something we're going to have to do. Do you know if, is it possible that these 30% that Representative Carpenter's already talked about that are in conflict, that they could, in a sense, be grandfathered in, and then any new, any people that are now coming into the program would then have to have this, be able to be in this new system with the, the having the no conflict?
Thank you so much for the question. I don't want to speak for CMS, but I do know that states that have had a, I wouldn't call it grandfathering, but maybe their conflict, their CAP, their corrective action plan included a phased-in approach, but that phased-in approach wasn't based on, individuals who have, for example, been with a provider for X amount of years. That phased-in approach went by a little bit in Ohio on services. So maybe phase one was people who were in service and maybe were receiving day program because that was a large group of individuals. So I can't say that, CMS, the regulation is in effect, and it's really your corrective action plan and how you set that up. But if you're asking if people that are in service, if they could be in conflict, and then anybody new coming into the system would have to be not in conflict. I've never seen that happen or be approved in terms of conflict of interest. But again, I'm not going to speak for CMS.
To piggyback on Representative Reese's thinking there, and I get that, and it is traumatic for folks to change, but also we've heard a ton of complaints over the last several years about how targeted case management folks are hard to hire, and the turnover is something incredible. So I'm not sure that that's something that I put a lot of faith in, other than just the fact that I know people are concerned about change, but a lot of times they change just because it's hard to hire case managers. And so, and Seth, you may have some information on that for later on about the turnover in, if you could bring that up in case managers. And so it's not like these folks are their case manager for their lifetime or something like that. But I do understand that a lot of folks, it is traumatic for them to change case managers, but we change them whether we like it or not also. So just saying that. Committee, further questions? Well, that was the total reason why we're here. And I think that we can develop and I think the department is working on this diligently, but I think we can do a Kansas plan that addresses, maybe some of our frontier areas and maybe some not grandfathering in, but I don't remember that. Yeah, stuff like that for our Western Kansas folks. But anyway, failure is not an option here. So we've got CMS that we're under a corrective action plan, and I'm not really interested in coughing up $300 million out of state general fund to fill that gap. And I don't think any of you are either. So no more questions? Representative Pickert.
Thank you, Mr. Chair. So I'm new to this committee, and so the 30% that have a conflict of interest, is that solely in Western Kansas, or, okay, it's all over? So how do we get a handle on who that is, and, and, yeah.
I'm hoping that the department has some answers for that question when they come back up after for testimony later. Committee, further questions? Okay, seeing none, we'll move on. I don't know, is Dr. Dean back yet? Okay. Do we have any what? Okay. At 11, okay. So Janine, thank you so much for being here. You've been very informative on that, and that's exactly what I wanted the committee to hear. So committee, we'll take a 5-minute break here till 11. Dr. Dean's supposed to be back at 11. So be back at 11.
Thank you so much.
get started?
Sorry, frog in my throat.
Need some water?
Yeah, I know, I might spill it, you're right.
Thank you for that, Senator. Okay, if we can kind of, I apologize for the interruption, but here we are back, and Dr. Dean is before us, so continue on.
All right, great. Well, I appreciate you letting me step away there for a little while. I had to get all my state business done today, so thank you. So where we left off, we're talking about the recommendations that we had put together. And so these recommendations are based on both the data and the analysis that we've done. We also surveyed a lot of all the states that have waiting lists to kind of better understand how they manage things. And then also we worked with the Self-Advocacy Coalition, we worked with CDDOs and families and others to develop these recommendations based on the data. So these represent a large coalition of people. So the first one is around data systems. And I know we've talked about this with the Bethel Committee and others before, but I mean, one of the things to really highlight here is that families need to know where they are on the waiting list, and they don't know, and have trouble accessing that information. So we really need a secure system portal where they can go in, know where they are on the waiting list, update their contact information, and better kind of interact with that. I think along with that is the public needs more information. So we really need a system that has a public-facing dashboard, so we can monitor both the overall numbers and geographical regions and demographic information, so we can monitor the performance of the system. And this is also going to help with those recommendations from CMS around reporting information about waiting lists in the future. So this recommendation would kind of help support building infrastructure for that. In terms of waiting list policy and procedures, I mean, I think we can probably all agree that eliminating the waiting list is the best thing to do. But we're making strides in that. I think the one bullet I left off of here is the community supports waiver. So I want to recognize that that's also a big piece of eliminating the waiting list, and thank you all for your work on that. But then also, so some other strategies that we can use. I talked earlier about the EPSDT services that can provide services for people under 21 on Medicaid. And then also, really building a robust, supporting youth through the transition from high school to ensure that they have the job experiences and the goals and the support that they need for work, post-secondary education, and community living. And this ties in here also with the need for a robust employment service system that people on the community support waiver are going to need. And in a little bit, I have some more information about some work we've been doing related to that with KDADs. And then also, I think, while we're eliminating the waiting list, other states that we've talked to have done some things like provide a minimum level of like case management and other services for people on the waiting list. Some people on the IDD waiting list have access to targeted case management, but not on the PD waiver. So just something to think about. So we can go on to the next page then. Just a couple other things, and I know we're, I think, building this in, but individual budget authority for The community supports waiver, I think, as we said, some of this data showed, families are going to need a lot of flexibility in how to use these funds to best support the person in services. And so individual budget authority would give them that, the flexibility and the choice and control that they need. Just hitting some highlights there. So yeah, we can go on to the next one. Here, especially, I think adding the community supports waiver, it's going to be good. It's also going to add more complexity to the system. So families are going to need some clearly defined procedures and navigators, targeted case managers that are informed and knowledgeable to be able to support families to make those decisions about which waiver to, do I get on a waiting list? Do I, which waiver would best support the needs of the person? Related to that we really need these decisions being made through a robust person-centered planning process. And KDADS has been building infrastructure related to that around the charting the life course and being sure that navigators and case managers are trained in using that tool, which I think is a really good step. But it's something that everybody's really going to need from the time that they're applying for services and then through different transitions in their life. So we can go on to the next one. And this is kind of reiterating that same thing, that families are going to need some guidance. Like, this is going to be a complex decision because it's the waiver services, and then there's other systems also through vocational rehabilitation and workforce systems and other services that are available that families are just going to need a lot of support. And we're hearing from a lot of families that there isn't a lot of support right now in making those decisions. We can go on to the next one there. So related to the robust employment supports that I was talking about, we've been working with KDADS to create some infrastructure for this, and just wanted to highlight some of the gains. And Kendra Criers is online also, and we'll talk about she's from OCCK, a provider in Salina and kind of north central Kansas. That engaged in a pilot project that KUCD led to build capacity for competitive integrated employment, which is employment in the community for real wages like everybody else, that I think has the potential to build a lot of capacity as we can roll that out farther. So you can go on to the next slide. And so just a couple of slides to kind of talk about that project. We kind of started this at the same time we were doing the waiting list project. But the big pieces of this, one, were to engage the community so that the policy recommendations and the work that we're doing is informed by the people that need those services and deliver those services. And then we worked with stakeholders in Kansas and also some national partners from the Institute on Community Inclusion at UMass Boston, which have been doing employment policy work for 30 years across the country. So develop policy recommendations. And then the piece I wanted to talk to today was a partnership that we did with WISE out of Washington State to build provider capacity. And we did had some really good outcomes from that. And then we did some other data collection and analysis as part of that too. You can go on to the next slide. So for the pilot project that we did to build capacity, we had 10 providers apply, and we used a blinded review process to be sure that we were just being fair in the selection process. So any organization that served people with any disability around employment could apply to be a part of the pilot. And we had some pretty diverse organizations from across the state that were selected as part of that. OCCK, as I said, in Salina, and Kendra's here to kind of talk about their experience, and they just knocked it out of the park. Starkey in Wichita was also part of it, Down Syndrome Innovations in Overland Park, and Compass Behavioral Health, the Community Mental Health Center in Dodge City and Garden City was also part of that. You can go on the next one. So what they got out of that, they received some, did some self-assessment and some technical assistance to just understand the needs. But the big pieces of it were mentorship from organizations that WISE had worked with in Washington State to develop capacity and business models for competitive integrated employment. So those organizations came out to Kansas to work with the providers here. The pilot providers also went to those organizations to see how things really worked on the ground. And then they met regularly to kind of talk about, how to train staff, how to develop a culture around competitive employment. And the other piece of this was training kind of the frontline employment services people with trainings that were accredited by the Association for Community Rehabilitation Centers, which is really the only organization that's approving training for employment service providers in the country. And then some wraparound training for families and youth. We partnered with Families Together in Kansas to provide a lot of support around that. So we can go on to the next one. So this is the really cool part. When we were developing the project, this is systems change and this is mindset change, and it takes a long time to do that. So we were estimating that across the 4 pilots, each site would probably get 5 jobs over the 18 months that we were working, because there was infrastructure that needed to be developed, people that needed to be trained. And right now, we're sitting at 176 jobs that that people have gotten across the state, and not just entry-level jobs. Like they're averaging over $13 an hour and working over 20 hours a week. So, with Employment First, we talk about real jobs for real pay, and that's what our results are showing here. That this training and technical assistance is building capacity, is really making a difference. This is 176 jobs across 4 organizations. So we're pretty excited about that. And this is without any changes to any kind of funding structures. We had some milestone payments that equated to about an FTE for the organization. So they had the ability to hire somebody if they didn't have somebody to focus on employment. We're really excited about those outcomes. Go on to the next one. And so this is just a breakdown from where people got jobs. Some in like Johnson County and Wichita and urban areas, but then a lot in more rural and frontier areas too, from Salina and north and out in Finney County and Ford County. So all across the state. And I think with OCCK was a big part, especially in their service area around Salina and north. And Kendra's on the line. She's the Vice President for Rural Outreach and Services. That's going to talk for a few minutes just about her experiences as part of the pilot.
Can we hold for questions for you first before we move on to Kendra?
Sure, yeah, that's great.
That'd be great. Kendra, can you wait for a little bit while we answer some questions or ask some questions of the doctor?
Absolutely.
Okay, very good. Committee, questions so far on what you've seen? Representative Bueller.
Thank you again, Mr. Chair. So when I was going through the presentation and I looked at the 2 aims of the study, what I'd like to know is, did you study the process of how someone goes about getting on the wait list, their services, et cetera? And the reason I ask that question is I've got 2 constituent families that I think about in particular, that one of their biggest frustrations, and one of them had a daughter on the wait list for 10 and a half years, was they never knew who to call. And that they don't know what the process is. So I don't want to presume based on the aims of the study, the two aims, but did you guys study the process and document that by any chance?
We didn't look into that very closely and didn't document. We heard a lot from families through the process that there were a lot of frustrations around that.
Okay.
But the process in general is that they would be referred to the CDDO to kind of be evaluated.
Yeah, and I guess
but-
and I don't know if you picked this up in your aims, but my constituents would tell me that's when this happens. The point you here, point you there. So I didn't know if that was mapped out or if it would have been nice. It would have been helpful for me anyway, but just a question. So thank you for that answer.
Yeah.
Thank you, Mr. Chair.
Thank you. I think we can follow up with the department on the process for assessments. Representative Ruiz.
On that wait list, I've heard so many families say that they get their child on the wait list right away because they knew it was going to be a 10-plus year wait. And so then when the name finally comes up, then the family has to decide, right? If there's a slot open, like, we gave funding for 200 more slots just this past session. And so if their name comes up, they have to decide, right, whether they take those services or not, or they stay on the wait list. But do they know that they go to the bottom of the list?
If they don't take the slot right then?
Yeah. Did they say anything about that, or any of the families?
We haven't followed up with families since they've been offered slots, because we only had contact information for people that were actually on the waiting list. So I hope they got that message, but I can't speak to it.
I don't know. All right, thank you.
Committee, further questions? Senator Rose.
Thank you, Mr. Chair. In your first presentation, at the very end, you made a comment that the wait list can actually increase cost because when they get coverage, they need a higher level of care. They're not doing preventive care because they don't have the coverage for it. Do you have an estimate on what the dollar amount might be, the increased cost because of the higher level of care because they're not getting the preventive care they need while they're on the wait list?
That's a great question, and we have some of the, we haven't analyzed to that point. I'm trying to think if from the claims data that we have, if we could analyze that. I'd have to take that back to our stats team to see if we could develop that, but happy to look into it.
Okay. Thank you, Mr. Chair.
Just for clarification, and I want to make this clear because a lot of people don't think that that's not the case, but 70% of the folks on the wait list are on Medicaid. And so they are getting their medical services. So just, I think sometimes we think they're just not out there. And then with the new EPSDT, which is something that just is new, I think we only funded it 2 years, I think. But that also gives folks that are not on the wait list an avenue to pursue services through that program. So there are some, and we might ask the department to explain that. I can barely say the acronym, let alone tell you what it does. But Representative Orpeza.
Thank you, Mr. Chair. So I have a couple of questions, and it was about your earlier presentation. You were talking about example of technology support. If you could give examples of that and the durable equipment, examples of that of what people were asking for. And then how did you define caregiver, family member, or somebody else? And then in this last part, you mentioned a part about needing to know where they were on the waiting list, and I wanted to know, like, what was the rationale behind that? What were the concerns, and why did the families or the people want to know why they were on the waiting list?
Sure. I'll start with the first one. If I forget the other one, just let me.
Sure, thank you.
So around the technology and the durable medical equipment. So the item, it was a survey item that people just could select if they needed that, and we provided some examples. So around technology, it was like everyday things like smartphones, using the map and kind of basic technology like that. Durable medical equipment is, things for people with more significant health needs, which could be, a wheelchair, like a transfer bench, or, other more. Well, I'm trying to think of other examples, but kind of higher cost and kind of disability specific kinds of things. Next
Sorry,
one.
my
Sorry.
my other question. I tried to
should have
ask all
written
this.
it down.
How was the main caregiver defined?
Oh.
Was that defined in your survey question?
Yeah, so it was, so a couple things, and we asked throughout the survey, but we really asked the person to identify the person that provided the most care on a regular basis for them. And so it was really up to the person to define who the caregiver was. And then we asked in the survey, some follow-up questions that are included in the final report. I don't have them in front of me, but to kind of, so it was mostly families and caregivers. Sometimes it was grandparents that were filling it out, but kind of people kind of within the household were most of the people that filled it out.
I just had the one last question about why they wanted to know on the wait list. Why did you said it was important for people to know where they were at on the wait list.
Yeah, I mean, what we hear, and I think what other people have talked about, there's a lot of frustration around, especially for the waiting list that's going on for 10 years. Families are trying to plan. Families are spending a lot out of their pocket while they're waiting for their waiver, while their slot to come up, and they have no idea within that time frame when their spot's going to come up. So they're trying to plan for the services and supports that the person needs, and just don't have the information, I think, that they need to do that.
Okay, thank you very much. Thank you.
Sure.
So just to follow up on that, will this study change that?
So I think our recommendation around, I think we're going to need a data system to be able to show people where they are on that list. This study doesn't necessarily do that.
So we'll hold that for the department to see where they're at on that, because that's how I envisioned this list. Once we studied it, we would have a way of tracking those folks that are on the wait list and being able to contact them or whatever. So, okay. Committee, further questions? Oh, Senator Thompson.
Thank you, Mr. Chair. Just curious, I guess, is there an ongoing effort to identify other employers who may have the capacity to hire some of the folks? When you're starting talking about the jobs, I'm just looking at the counties where there are jobs, but there's an awful lot of counties where I would imagine there's some entities that would be capable of taking people on.
Absolutely. That was a big part of the mentorship and part of the training that was a part of the pilot study, was to work with organizations to really think about marketing both their organization as a supporter of people, and that people with disabilities are good workers and valuable for the workforce. So that was a big part of the training, and to kind of build capacity for organizations to be able to do that. And Kendra might speak a little bit about that too. There are, the workforce system too is another example. I think there's ongoing efforts in the state to really work with employers around hiring people with disabilities too.
Yeah, I was just curious about what the potential for expansion would be, so, in that area. Thank you.
I agree.
Thanks,
I think there's
Mr.
a
Chair.
lot of room. Yeah.
Senator Owens. Committee, further questions? I just have a couple. So we studied this wait list. How accurate is our wait list numbers? And when let me quantify that. that are ready for services today. Because exactly what we've found is that folks know that their child's going to be, or whoever the significant other is going to be on the wait list. They sign them up and they're eligible at 5, So at 15, I mean, how many are those of the 4,800 people that we have on the wait list are that person or those people versus how many people, if we said, we have services available today and they could take that?
Yeah. It's a great question. I think first, especially for the IDD waiver, like everybody on the waiting list is qualified for services, so need some support. But I think, so I'm going back to our numbers. There's about 2,000 people that are over the age of 21. So those are the people that don't qualify for EPSDT, aren't in the schools receiving services, and then those kinds of things. So I think that's probably the group that we can't really serve in other ways, other than for employment and things like that. So I think that's probably the best answer I can give. I think there's probably are people that need those services that are younger, but I think that's probably the highest need group.
Very good. Thank you for that. And the other question I had, just to refresh my memory, what was the percentage of people that returned the survey?
We surveyed, this is going to be rough numbers, but we sent it to all 5,000 people, and we had about, for the survey of people on the waiting list, it was around a little over 1,000. So it was about, I think, an 18% response rate.
That's the way I remember it, and I remember how disappointed I was when we're talking about people's services that only a fifth of them returned a survey that really was about the future of their significant other. I just couldn't believe that number. You would think that when they got that in the mail, they would fill that thing out, and even registered letter it back to these folks. So, yeah, I don't know how so quite frankly, with that, you don't have any information on those folks either.
On the information on the people that completed it, or?
No, the other folks that didn't complete it.
No survey information. They were included in the analysis of the administrative data, like the crisis exceptions and like just the kind of general information about people on the list, but not the more detailed information from the survey.
So 4,000 of them, we don't have any detailed information on what kind of services they would need if they were offered services.
Yes, I do think that with the sample that we had and a response rate of 18%, like in the in the research world, we're pretty confident that we can kind of apply these to the larger group, but I understand the kind of practicalities that may not look like that.
Yeah, exactly. All right, very good. Committee, any other questions? Very good. Doctor, thank you so much for being here and answering those questions. If you think of anything later on, committee, certainly write it down or something, and I've taken up a lot of his time over the years.
I always appreciate our conversations.
Yeah, well, thank you. Thank you very much.
I will stay around through Kendra's presentation, so if you have any other questions for me about the project, I'll be here for that.
Very good. Thank you. Kendra, are you still there?
Yes. Can you hear me?
We can hear you fine. Welcome to committee, and thank you for your patience.
Well, thank you for having me. Can you all see the slides? I'm not able to see them, but if you can see them, that's okay with me. Oh, there we go. Okay, well, I am Kendra Creer. I work here at OCCK. I've been here for about 19 years. currently Vice President of Rural Outreach and Services. And next slide, please. Okay, so for the Employment First pilot, kind of one of our first tasks was to come up with a name. So our team's name we decided on was the Career Compass Navigators. And kind of how we went about that was we sat as a team and just really explored many different team names. But to OCCK, it was more than just looking at jobs, although that's a piece of it. We really wanted people to start thinking about a career. So our name became the Career Compass Navigators. Next slide, please. So who is OCCK? OCCK is a diverse organization that serves people with any kind of disability, any age, long or short-term disability across North Central Kansas, and is committed to inclusion. Not only do we employ people with disabilities, but our board of directors are people with disabilities. OCCK truly embraces opportunities to lead new initiatives that really support our mission. And so some examples would be the Employment First pilot, IDD Crisis Stabilization Grant, and the Tech First Grant are just a few. OCCK continues to grow and diversify. In 2024, we were at 325 plus employees, served 5,747 people, and provided 318,000 plus rides statewide. Next slide, please. So what did we learn through the employment efforts? With anything, there's always the hard and then there's the good. And so to be 100% honest and transparent, this really took us and made us take a deep dive into seeing where employment was at for us. Looking at where we were at philosophically, did we as staff really believe employment is important to people? What training did our staff have? And did we have enough staff to do what we needed to do? This pilot, it really brought everything to the forefront for us. We saw, and we were talking about living and housing first with people before even approaching that employment conversation. We also heard, I can't work, or my son and daughter, son or daughter cannot have a job. So we really knew that there was work ahead of us. But with the good, we found out people do want jobs. Employers are willing to work with and meet with us. Being able to talk about power and the independence of employment, it does the same really for all of us. If we believe that people with disabilities are the same, have the same rights, then employment should be one of the first conversations we were having instead of one of the last ones. It is hard bringing different departments together. We took kind of a different approach, and we brought our brain injury program, our autism, IDD, workforce solutions, kids and adults all together. And that was hard, everybody having a different look at things. But truly watching a team with many different specialties come together to drive employment forward and be eager to learn and receive training around employment, it was truly awesome. Next slide. So you always, when you start something new, what questions we asked ourselves, and these were some of the questions that we asked ourselves. But for more than 50 years, employment, it has been a priority for OCCK. We work hard every day to help people gain independence in all different parts of their lives. Getting a job, that gives you a level of independence. And with that, like I said before, it's not just looking at jobs, also looking at careers, helping people explore and discover what their interests are. Is it just getting experience, or is it maybe looking into secondary education as well? We come across people are told every day that they can't. And we really try to avoid that argument of who can, who can't, and really start educating people and families when they're young, and educating schools that employment is a very important piece of adulthood. When looking at employment and sheltered workshops, It's not an all or nothing. It has to be person driven. OCCK took what some would call a unique approach to develop the Career Compass Navigating Team. We have staff from, like I said before, IDD services, autism, brain injury, workforce solutions, self-directed services, some physical therapists, occupational therapists. And the reason of taking this approach was to really educate and train staff around employment that work with people of all ages. Through that, we've had some excellent feedback from community partners that we have partnered with for many years, and new partners from people talking. You know, being in a small town, word spreads pretty quickly. Staff, when talking to them, staff feel like this pilot has provided them with the opportunity to obtain training to really focus on employment. And that just naturally filters to folks we support, to their families, and others as well. Advancing supported employment is a continual discussion and advocacy in the state. This is done by talking to all of you and giving testimony, and being a part of different work groups within the state. Next slide, please. So our vision, I think I've said it over and over, is OCCK is making employment a regular part of life for people with disabilities. Next slide. So here are kind of our next steps, and what we have done throughout this pilot is just, you know, leverage OCCK's positive reputation, broad organizational structure and programs, structure services that support housing, transportation, relationships, and complement employment. Next slide, please. So leadership ownership, this came with us when we kind of took a deep dive. Is what does everybody believe? We have to have ownership at the leadership level here at OCCK. Not only do our employment discussions happen at a direct support professional level, they are obviously happening at that level as well, but also planning, you know, throughout 2025 in our leadership meetings with our leaders, so we can truly hold everybody accountable when it comes to employment. Next slide. Another big part is something that we always do is, you know, share our employment vision with the board. Gather their support. Let them know what we need. Is it staffing? Is it outreach? You know, what that may be. And having those honest, ongoing conversations, you know, at every board meeting about how it's going, what we're struggling with, what is going really well, really broadcasting it. And they're truly excited to move forward with us. Next slide, please. So building infrastructure, you know, is that looking at, you know, databases and training for job developers and job coaches, really making those inter-team collaborations, you know, having technology at the table and an occupational therapist at the table, whoever that may be, benefits planning. Right now at OCCK, we utilize a database that have builds specific to OCCK. And this is nice because it can track our outcomes and where we are at with people in the process of employment. Continuing to get staff training, certifications, experience, and continue to work with benefit specialists for now. Obviously, we would love to at some point have a benefit specialist in-house and just kind of at our fingertips. Next slide. So advocacy, you know, just having the joint education to MCOs about sustainable reimbursements, engaging VR, KDADs, legislators. I think it is so important to really take that advocacy to the earliest stage possible, talking to the youth, talking to the families, getting everybody on board there, you know, reaching out to schools and having those sit down conversations about, are we talking about employment? How do we talk about employment? What can we do as a service provider to bring that in and educate families and the school and everybody else. We've partnered with Families Together in the past, as well as brought in other employment-centered trainings and doing what we can there. Also, I just kind of wanted to throw in a little short story. And I think this is kind of that advocacy effort. So it is with the community support waiver, which I think is a beautiful idea. It's my understanding that the community support waiver is not an aggregate waiver and has a cap of $20,000 per person. So I'm here today to talk about employment and people and to lead around people and not necessarily a cap. In rural Kansas, jobs are limited. And it takes an immense amount of upfront relationship building for us to build trust with businesses before we even start assisting people with finding jobs. Through the Employment First pilot, we have assisted over 85 people in getting jobs. And I'd just kind of like to give you an example of what success for us has looked like. So in north central Kansas, in a town with a population of around 5,000, we started working with a gentleman that not only has a developmental disability, but also a psychiatric disability. We started supporting him while he was in crisis and just getting out of prison. The services he started with were day and residential. We also had a crisis team wrapped around him as he was struggling. This man is successfully working in the community, rents his own house, and is working through his struggles along the way. Here is what we have done to assist him in being successful. On-site job coaching, not only when he started his job, but when he starts to struggle, we jump right back in. And sometimes we're job coaching for months at a time as he's kind of navigating that struggle. Assist him with maintaining a relationship with a supervisor, especially when that struggle starts to happen. Transportation to and from work during the week and on weekends, because there's not public transportation for the times he works, which he typically starts his shift around 5 p.m. and gets off work anywhere from 11 p.m. to 1 a.m. When he is at home, we're providing independent living supports. And when he's struggling, we're wrapping a really comprehensive crisis service team around him, along with different therapies. Having technology not only at home, but on the job. And to say we are proud of his success would truly be an understatement. But to me, kind of the takeaway is most people that are going to work are going to fall in this category of odd work hours, transportation needs, on and off crisis supports, when things fall apart. And it's hard to build a really good plan around people in communities with a cap. I think flexibility is going to be so much needed around this. Next slide. And then just broadcasting. I feel like for OCCK, broadcasting is an area that we should probably improve on. Sharing our success is something that we should continually highlight because we are seeing people become so successful in their communities. And one of the things that I think is worthy of highlighting is for OCCK's 50th anniversary, we've set funds aside for a scholarship fund, and this is for kids with disabilities of any type that are looking at trade school, secondary education, and really going and furthering that. And that is all I have.
Very good. Thank you, Kendra, for that. Committee questions? Representative Bueller.
So this is a pilot. What is, in the presentation materials, it refers to selected through a blinded review process to receive ACRE accredited training by a stakeholder group. Is there are there actions beyond the pilot intended? And I don't know if that's an open question or. Please.
Dr. Dean, state your name, please.
Thank you.
I am Dr. Evan Dean. And if we could go back to that, well, in your packet, there's one more slide there. Really based on the success of this pilot, we've partnered with KDADS to open up the pilot to more communities that we're hoping to start here at the beginning of the next year. So, and it's, I think we have the infrastructure in place and the partnerships in place to be able to sustain that long term if the funding's available. I think that's been the real challenge, is to figure out how to keep that funded.
If I may, a follow-up. So what, do you have any idea what the funding requirement is, so to speak, to go beyond the pilot, is it specifically? Thank you.
I'm trying to remember what we just submitted. But so what goes into the budget is both our time to kind of organize and coordinate the funding, then the partnership with WISE and ICI to provide the technical assistance and the mentorship, and then funding for the organizations to reach the milestones that go through that. So I want to say it was close to about $2 million to go through that. Mm.
And is that, it used to be it was a 90-10 federal match. Is that still in place, or did we miss that for Employment First?
So the pilot was funded through ARPA funds, and I don't, was there a match? Or yeah, not for that. Yeah.
All right, thank you. Mm-hmm. Representative Reeves.
Kendra, I just want to commend you for all the work that you and your team have been doing. This is just, the numbers are just extremely impressive. On slide 43, you have built infrastructure. Thank you for that information, because this is really good for us to look at. I'm especially interested in the benefits planning. Can you say just a little bit more why that's important?
Yeah, sure. Thank you for the question. I think it is important because there is a lot of fear within families that, you know, if my kiddo goes and gets a job and makes too much money, then they're going to lose services. And so what is really nice is having a benefits specialist come in and sit down with the family, kind of talk through those fears and show, you know, your kiddo could go get a job and make X amount of money, and it won't affect services at all for the person. You know, they won't lose their eligibility. They won't just have the job and then be left with nothing, because many times we find families are and people are excited for employment, but there's that fear. And then what if they go get a job and very successful, and you know everything's going well, and then they start to struggle or something happens and now they've lost their job, they no longer have, you know, eligibility, and then it's just kind of that start back over and reapply and get on a waiting list.
Committee, further questions? Well, thank you, Kendra, for being here. We appreciate you. Okay, committee, I guess you've made it easy on yourselves. We're going to break for lunch. See you at 1:30. Meeting back to order. Thank you, committee, for coming back from lunch. Appreciate that very much. Staff, thank you for coming back for lunch also. Conferees, thank you for being here. We're going to go ahead and get started. The next one is, Seth, are you up next? Review of state compliance efforts and plans to comply with the federal targeted case management rules. Very good, Seth. Welcome back.
Yeah, good afternoon, committee. Yeah, so this afternoon I will, like I said, as earlier, I'm Seth Kilber. I'm the Assistant Commissioner for the Long-Term Services and Supports Commission in the Kansas Department of Age and Disability Services. I will be reviewing some of these modernization consensus work group updates this afternoon. So to provide just a little bit of context, last year, the department had announced some modernization efforts of the IDD system. There were a lot of, as a result of some of those efforts, there were a lot of concerned stakeholders. I think many of you probably heard from them as well. And so that really presented an opportunity for us to really take a step back, pause for a sec, and really, convene with our system-wide stakeholders on the direction we were going and try to really build some consensus. And so what I'd like to do this afternoon is really provide a roll-up of what those recommendations, what the output of those consensus work groups really presented, and hopefully provide a direction that we plan to move going forward. But this really comes down to three key components. Number one, obviously what you've heard today thus far around the federal requirements. We do know we've got to comply with CMS final settings rule expectations around particularly the conflict-free case management, but as well as ensuring that the services that we design are meaningful and actually integrate folks into their communities of choice. And that's particularly around person-centered planning and the federal reg there. And then stakeholder input and readiness. So we've really tried to be really engaging lately of individuals and services, families, providers, anyone really who has an interest in the system to hear their concerns, hear their input, and engage in those work groups, listening sessions, and some targeted technical assistance around the efforts that we're undertaking. And then, of course, the other big component to this is implementation of the community sports waiver, which I know many of you are really eager to see us get that up off the ground and to an effective waiver. So just to recap some of the federal compliance portions of this, what Janine Zlaki had mentioned through with NASDs on the federal compliance piece. Just to reiterate this, the conflict of interest regulation. I won't read that verbatim for you, but there it is cited for you. Another component of this is. Sorry, not a component, but I've also got cited in there that CMS had written the state a letter in December of last year that states a key component of this regulation is the conflict of interest provision. Kansas is not compliant. The state needs to take all necessary steps to ensure this compliance, so CMS does not have to consider formal actions, which could include withholding federal reimbursement. So again, coming into compliance with this regulation does ensure that we're able to protect the federal share of these services. And then another element of this regulation cited a little bit further down is, and something that CMS has continually reiterated every time we talk with them, is that any new waiver application must fully comply with the federal regulations. So we know that there's no protection for us on this new waiver application. So this new community support waiver has to fully comport with the federal regulations from the very outset. So with that as the backdrop, I think it's helpful to understand what is the broader vision for some of these modernization efforts beyond just fully complying with federal requirements in the new community support waiver. We've got three buckets here that these efforts kind of dovetail and work together on improving access to services and expanding individual choice and strengthening the quality and consistency of supports across the system. So those buckets are fall into access, choice, and quality. Under that access umbrella, we've got obviously the community support waiver and the MFEI, or the Medicaid Functional Eligibility Instrument, which is the assessment tool that determines whether or not somebody actually qualifies for the IDD waiver. Choice, there is unbundling day services, conflict-free case management, and person-centered service planning. And then under quality, it's how we actually define some of those service definitions and some of the policy considerations around that. And then how is the state and our other partners doing the monitoring aspect. And then Enter RAI, which is a needs-based tool that helps determine what services people actually want once they're on the waiver, and rates and methodologies around how things are reimbursed. So, with that said, we had a number of consensus work groups meet over the spring. I think over about a 2-month span. We had, I think there were 3 groups that met around conflict of interest, person-centered planning, and unbundling. There are a couple of different offshoots of those groups that also met. Somewhere around 100 different stakeholders were participating in these consensus work groups. And we took everything we heard over that, that 2-month window and rolled that all up into pretty much a 3-phase approach into 3 different phases, including number 1, really we know we've got to solve for the conflict of interest part of the federal requirement. So that really is where the bulk of our effort is today. Then where we've kind of oriented ourselves, the direction we've set based on these consensus recommendations, is that there will be no dual service provision under a conflict-free system within Kansas. So this does align with our work group recommendations. It's going to require us to map the current state and the future state, defining those swim lanes for what each entity is able to actually do and perform. And then a lot of communication is still what we're undertaking right now, and there's really no end point to communicating that you just can't. I don't think there's such thing as over communicating some of these things to the system, and that's something I think that we have really internalized recently. And then drafting, I think there's been a lot of interest. This is something from a year ago that we weren't, quite honestly, really interested in pursuing, but hearing the feedback from the stakeholders and looking a little bit closer at the data is drafting and vetting an only willing and qualified provider exception policy. So that is something that we know we've got to really figure out soon to be able to get that into this community support waiver submission. And then beyond that, establishing some of those compliance and monitoring, the quality oversight mechanisms to ensure that, once we've got a system that is conflict-free, how do we ensure it stays conflict-free? Because it really only takes one person to be not conflict to take the whole system out of compliance. So we've got to make sure that we've got processes in place that we can remain a conflict-free system. So that's phase 1, and then let me take a breath real fast because I'm just like lightning through this. Okay. Phase 2, consolidated person-centered planning. This one is a little bit more nebulous, but I think what we've really been hearing from families is that they want a more streamlined approach to how the planning process is done. Right now, we've got a system that has a lot of cooks in the kitchen, but that can be confusing on the receiving end, the person we're actually trying to serve ultimately, right? So we're trying to reduce the number of hoops that they have to jump through, the number of meetings, the number of assessments, all of that stuff, and that's a hard task to do, but we think we can get there, and we think that we can almost use the community support waiver to make it to design it in a way that works better, and hopefully we can then take that and take some of those lessons learned and eventually bring it into the IDD waiver as well. But some of those recommendations include drafting and vetting how person-centered plans, the documentation structure, and how that is all shaking out, reviewing policies, procedures, contracts, and identifying any changes needed there. And then mapping how rate modeling and that structure will flow through MCOs, TCMs, and how that actually impacts reimbursement and the planning process on that front. And then finally, with phase 3, we'll be looking at unbundling day services. So the key components there are, obviously we've got to draft those service definitions and reconcile with whatever rate model we have, and then drafting and submitting a waiver amendment for our corrective action plan compliance, and then reviewing implementation plan options. So all of the operational elements, how are the services authorized, how are they defined, and how do people know when they're in certain categories and such.
Seth, can you kind of go through that day service situation for us? What is acceptable? What isn't? I think there's some confusion about the actual day service unbundling, and
yeah.
So
I actually have a slide in there a little bit later.
You do? Okay.
Yeah.
Very good. Thank you.
So to unpack this a little bit further, I can get into the no dual service provision. So what do we mean when we say no dual service provision? Essentially, that is, if you're a provider organization who offers both waiver services and targeted case management services, you can do both of those. You don't have to pick one or the other or drop one, but you just wouldn't be able to do it to the same individual. And so we could talk a little bit about what that actually looks like for those current individuals who are in a conflicted situation, and the challenges around that. But that essentially is the direction that we've set. Now, the caveat here is we're now looking at only willing and qualified provider exemptions as well. And so there's a whole host of policy pieces that we need to put together on what does that look like. You have to define, what does only provider in an area mean? What does willing? You have to define each one of those elements and be very, very precise and articulate about what that actually means from an only willing and qualified provider piece. And then there's a whole application that needs to be reviewed annually and those sorts of things. But what we've started to begin that work with the group, and I'll speak more on that in a few slides. But this also does allow for multiple compliance pathways. So agencies could choose to divest and only focus on waiver services or only focus on case management. They can do both. So it's not like we're locked into one or the other right now, but that is the direction we are going, and then it does align with federal expectations around how states could potentially resolve this. This slide just drills down into a little bit more of the detail, where conflicted providers can support that internal separation or full divestiture, but obviously a lot of folks prefer some of the phased and a more flexible approach. So that is aligned with with our direction, talked about the only willing and qualified component of this. I think that provides some safety net for those areas with limited provider choice, and I think there's a lot of eagerness to understand what that process will look like. And I mean, I could speak for myself. I'm really eager to know what that end state will look like too. I don't have the answers yet, but we're working towards that and hope to have more information there in the coming months. And then with that, obviously comes with enhanced state oversight. You know, like I said, once we're in compliance, we got to make sure that we remain in compliance and that we can assure CMS that we've got processes in place to make sure that we don't fall out of compliance or backslide. And then I touched on this too, but the divestiture of TCM or service provision, that's still an option. So providers can choose that, but it's not something that we're trying to force providers to make a decision there. And then another recommendation that was talked about a lot was administrative service organizations. This got a little bit of a mixed feedback. Some folks supported it. Others had questions about feasibility and some of the oversight. So it was a more complex option than something that wouldn't necessarily be able to be stood up in time for us to be able to submit to CMS and get our new waiver up and running. So that just I put that in there just to really illustrate the some of the particular recommendations that were made and how they fit within the overall direction that we have landed on. So with consolidated person-centered planning, the direction we are moving is target case manager will lead the development of that person-centered plan. MCOs are going to complete the inter-RAI assessment and determine funding cap. MCOs, as of a couple months ago, are already doing the inter-RAI now. Previously, they were each doing their own assessments. This gives us a much greater window of insight into how those assessments are, and now we're working on collecting that data so that the state is able to have that window into how those needs are determined. And then being able to use both that data in conjunction with the MFEI for the TCM to support how that overall plan is developed, that then drives the types of services and supports that the person receives into a consolidated plan structure. So as I said earlier, this aligns both with the feedback we've been receiving from particularly families and those in services, and even those whose jobs it is to support the planning process, how cumbersome that is to work through. And so we really want to be able to structure this phase in a way that streamlines the process overall and really eases some of the burdens placed onto the system. With the third phase focused on unbundling of day services. So this is about replacing our current existing day services with new distinct service categories, and really about increasing choice and flexibility for individuals. We've got a work group that's it says to begin, but they've already begun on reviewing what our proposed service definitions are and kind of fine-tuning and tweaking those into something that it will be workable and operational, and then in a way that also, of course, aligns with the settings rule and community integration mandates and those sorts of things. Next slide is talking about current day services. So I think this gets to your earlier question, Representative Carpenter. So today, right now, we've got there's basically one day support option. Well, I guess quasi two. We've got day supports and we've got employment supports. So day supports is a service that is community-based, meaning it's got to be outside the home. You can't bill day supports typically if somebody's in their own home. And it's got to be aligned with, like I said, someone's person-centered service plan. Typically, it's delivered by agency-directed community service providers or shared living contractors in some select instances. And it's scheduled in blocks of time, so it's capped at 25 hours a week or 115 hours a month. And it covers, all of those things: socialization, recreation, community inclusion, skill development, and some providers are also doing like some pre-vocational skill building, employment type supports. So it is not designed as traditional employment or job task training, and really what the some of the impetus for us needing to unbundle these services is CMS for years has basically told us that this is too broad of a category. You're capturing too much under the sun here with this service definition. If you've got providers doing any sort of employment-like supports under this day habilitation code, you need to pull that out of that service definition, because we do not, speaking of CMS, we do not want you to be covering employment supports under a day support code. So that's really what this kind of is the driving force beyond that. So we know we've got to get employment-like services out of day services. It's just a matter of what does that ultimately end up looking like. Kind of building on that, employment-related services. So there is no day habilitation or work center 14C sheltered workshop service built in. I think this was a question from Bethel, last Bethel, about if the community support waiver is going to have day supports or 14C type services on the waiver. The short answer is no. It will have the community support waiver. Right now, what we've got in there are these three services that folks will be able to choose from. Life skills, which is really about equipping folks with basically those abilities necessary for full independent living. So targeted towards anyone who, particularly or maybe transitioning into young adulthood, all of those skills needed to successfully navigate adulthood. Career exploration and planning. So that is really looking at, do I want a job? What kind of jobs are out there? What could I potentially do? So all of the application, career field exploration, resume management, all of the things around what a person needs to do to potentially prepare and get a job. And then we've got a service on the IDD waiver as well, but supported employment or individual employment supports, which is once somebody does have a job, if they need a job coach to follow along, a service that will reimburse a job coach. So, like I said down there, CMS requires, or had said previously, but the community support waiver does need to comply with the settings rule. So that's much of the reason why we can't propose a service that funds segregated center-based employment, because we just know right away that CMS would immediately kick that back out to the state and not approve it. So what we've shared these recommendations out with the larger group that took part in our consensus building process. This is some data on what we've heard. It's not the largest sample size, but it was a short survey just to get their feedback on where we are and what they were sort of expecting out of that. So out of 84 participants, 21 responded to our survey. Nine from our Family Advisory Council, and 4. Sorry, I'm reading this wrong. 4 out of 9 on the Family Advisory Council responded. So there we go. You can kind of see how each group viewed the clarity of our presentation and the direction we were headed. Most 43 and 47% found it mostly clear, somewhat clear. Out of the modernization work groups, Family Advisory Council, somewhat mostly clear, 58%, 19% respectively there. And then the next one is just some more survey data on how the modernization direction aligns with their own ideas for compliance. You can see down there on the left-hand side with the modernization group, 62% felt it mostly aligned, and another 19% felt it somewhat aligned. And then numbers kind of somewhat mirrored there for the 4 respondents on the Family Advisory Council, 50 and 25% mostly or somewhat aligned there. So some of these key themes from the feedback is, we've really been generating open-ended feedback through some more, formalized presentations, but as well as informal discussions with Internet members and stakeholders and self-advocates, and other comments that we receive via email or whatever avenues. So we're really trying to cast a wide net on hearing from folks. And this is what we've really been hearing so far, is that people are really eager to be engaged and stay engaged, but they're cautious. So the direction is somewhat clear, yet obviously the devil's in the details, and people want to know, what does this look like when the rubber meets the road, and how it's going to impact them directly. There's a lot of concern and focus on choice and capacity and transition. So those are things that I think we really want to get into and unpack a little bit more, but about capacity of TCM, particularly in those rural areas and those areas that might have providers needing to apply for that only willing and qualified exemption. And just the need for how do we as an agency explain this to folks and who are going to be impacted in a way that's very clear and articulate. And then there's a kind of connected to that is the desire for clarity and predictability. People want to know what's the timeline here? What are we looking at? How is this? What are the expectations for me moving forward? And that just reflects the need for us to continue to engage in communication and be as transparent as possible with people. And then finally, families want that direct and relatable messaging. So seeking reassurance about how services will continue to meet their needs and preferences. And so that's really the bottom line, is that even though we've got to make some of these changes, that at the end of the day, people are still going to receive the supports that they need to live the life that they've identified. So next steps. Like I said, we don't feel like that we can be in a position where we're over communicating. So we still intend to provide support strategies and clear, consistent communications to include all of these components here, clarifying timelines, implementation expectations, so everyone knows what to expect and when. Developing some of those policy components on compliance guidance and plain language materials, frequently asked questions, maybe visual flow charts, just really at a high level, helping people understand how this is all going to fit together. Because if you're sitting on this committee, I think you probably understand the system is just quite complex. And so it's my job to understand this stuff, and it makes my head spin. So I just know how families and people receiving services can get kind of just lost in all of the complexity of it. So we really got to do a better job at explaining this in some plain language. And then exploring additional supports, potentially including a second round of grant funding for providers to come into compliance. That's something that we are interested in seeing if we can make happen. And then, tailoring communications by audience. We can't take a one-size-fits-all on communication. There's communication specific to providers, communication specific to case managers, families, people receiving services. And so really just trying to understand how we can make sure our communication is hitting the right people. And then, kind of dovetailing on that, just expanding those outreach channels through webinars. We've got one tomorrow night on this topic. Additional town halls, written updates, just making sure that those channels are open and there's feedback loops that we're sending out stuff, we're hearing back from people, and it's filtering back up to where we need to, so we can continually refine our messaging. So my last slide here on the next step is one of the outputs from these consensus work groups, and knowing we've set the direction, but there's still a lot of details still to be worked out. Was the formation of this policy alignment team. So we've assembled a small team of stakeholders, self-advocates, providers. Really focused on getting people into that group that have an in-depth understanding of the system at all levels, both on the receiving services end all the way up to seeing things more on the systemic side of things, and who have been around a long time. And this group is really going to help the department vet some of the policy directions and some of these modernization efforts. So beginning with this no dual service provision and only willing and qualified providers. So, tying it back to the phase one, that's the current phase that we're really trying to solve for. Some of these things are happening concurrently, but we know right now that we want to be able to get language in our community support waiver submission through this group, and hopefully they can help us kind of craft and some of the actual waiver language and policy pieces that are going to come down the pike here. So this will be we're trying to make this as transparent as possible. So we'll have membership published on our Conflict Free Kansas website with minutes and notes and everything. So other folks who maybe aren't able to participate in that can kind of see what we've been talking about and where we're headed. So with that, I will stand for questions.
Very good, Seth. Thank you for that. Senator Thompson.
Thank you, Mr. Chair. Thanks, Seth. It's been a little while since I've been fully immersed in this, so I appreciate all this update of where you're at on the waiver situation. And remind me of the providers that we have in Kansas. Do they all provide dual services?
No.
So, in other words, by separating it out, how much of the state, territory-wise, will it make it difficult for people to get the services they need, the day services versus the employment services?
Yeah, we're that's kind of one of the next steps here is really vetting some of the data that we have available to us and crossing that with the data that providers have. So I think that's something that we're getting ready to really dig into with that policy alignment team. We indicated roughly 35% statewide are in a conflicted situation, but there's incredible variance of percentages based on, particularly CDDO catchment areas. You have those folks out west who maybe are seeing, numbers much higher than 50% in a conflicted situation. And so I think that's kind of the next step, to helping us define what those timelines look like for those folks.
Yeah, I was kind of curious. I couldn't remember for sure just if all of the agencies that we have or the providers that we have cover the entire state, or they just focus on certain regions?
Some do cover the whole state, but the way it works in the IDD system, though, if you're a provider, you have to affiliate with the CDDO in which you want to offer services. So there are providers who go in, 27 CDDOs. Sometimes that can be a little bit of a barrier to do 27 affiliation agreements. Yeah, there are some providers who have made that leap and cover the whole state, and others that are really just in maybe one CDDO area or two.
So it sounds like the like you said, defining the only willing qualified provider is going to be the real trick there.
Yeah, and once we have, I think once we have some more hard data to really rely on, and we can get that information out there, I think those other providers will be able to see that and go, oh, hey, this area, this pocket of the state is going to present an opportunity for me. So maybe I, as an independent TCM agency, will make that leap into the CDO catchment area because I know that there's going to be folks who will choose me.
Thanks, Seth. Thanks, Mr. Chair.
Representative Pickert.
Thank you, Mr. Chair. Thank you for all this information. So I meet occasionally with groups of parents and people who have IDD and PD situations. And as was stated earlier, it's really hard for them to change, and there's a lot of anxiety that goes with that. So I have a meeting coming up, and so I know you don't have any definite timelines, you're in the planning phase, but do we have like a deadline to meet the CMS? I know it was 2014, wasn't it, when it was supposed to be done, but just anticipating, are we talking in a year, 2 years, just kind of general? Do you have any idea when this is going to be implemented?
Right now I can't overstate it, but we're really focused on this new waiver. Like we know that is probably the highest priority for us as a commission and department, with the understanding that whatever we put into this new waiver is likely going to be ported into our comprehensive waiver. Since we are under a corrective action plan for that the existing waiver we have right now, there's a little bit of wiggle room. So to answer your question, I don't have a date. Like there's no drop dead date. Yes, we've got to be in compliance by this date. What we do know is that CMS is going to want to see a plan with milestones on how we're going to get there. So if it's detailed enough, I think there's an opportunity for us to have a little bit of back and forth with them on what that date ends up looking like. But they won't accept just we're working on it, trust us sort of plan. But we hope to be able to define some of those steps in that date in the coming months with this policy alignment team that I spoke about.
Well, I don't know much more than I did, but thank you for trying to. I appreciate that.
Committee, further questions? Do you need some help with the deadline?
The PAT members, our policy alignment team, I think are really going to help us define that. We've had examples of states that have taken up to nearly 10 years to come into compliance on their transition plans. We know our IDD waiver renews again, so that waivers run on 5-year cycles. It will renew again in 2029. Personally, I don't have much interest in extending it beyond that date, but that is something I think we're really trying to nail down.
Committee questions? I want to go back to your slides, starting with slide 10. So the yellow deal is partially aligned or conditional alignment. Divestiture of TCM, target case management and service provisions opposed by most stakeholders due to disruption of provider operations, participant choice, viewed as overly disruptive and not reflective of community needs. So how are we ever going to accomplish that with that kind of opposition? Is that how I'm reading that?
I think it was if the state were to take an approach that says only divestiture is the compliance path, is where the opposition is coming from. So provider organizations can still choose to divest from waiver services or TCM services, but it's not going to be a mandate at the state level that they do that. It just means if you're going to do both, You just won't be able to serve an individual for both waiver services and case management.
Okay, all right. Slide 14. So this is kind of the one I think that has a lot of people upset. So basically, we're talking about no more sheltered workshops.
No, I don't know if that's a decision that's been fully made, because there's a lot of different definitions when we talk about sheltered workshops. So what we know is that there are, and I think we can provide some information. There's even a 2011 letter from CMS that talks about employment services and how they want states to the taxonomy of the HCBS waiver codes and things that can be covered and not covered. But with sheltered work, it's not that people can't go to a sheltered workshop. It's just going to be how that service is defined in the waiver. And if it's either an employment-related service or if it's an actual dehabilitation service. So there's some open-ended question about like what does that actually look like. But for the community support waiver, there will not be.
Right, but we're talking about this waiver here. So just to give you an example, in my service provider, they pick up, I don't know, 30, 40 kids a week. They take them. They don't do much. Some of them shred paper that are able to. They used to build some widgets or some, you know what I mean, stuff like that. So will that happen? Will that be able to happen?
Potentially. It's kind of dependent on are they being paid? Is it considered an employment-like service? Is it, or are we framing it more as like a volunteer skill building? So that's I think where it's going to get really tricky and why we're having these discussions with that technical writing group that's really focused on these unbundling definitions, and we're leaning on help from Dr. Evan Dean and the KUCD group that they're working with some national experts on helping us to define some of these services and taking best practices from other states as well on how they've resolved this issue, because it's not new.
My theory is that if these folks weren't picked up and taken to that day shelter, they would spend the whole day at home watching television and so it's just hard for me to believe that can't be the best interest, that can be the best interest of that child versus getting out and socializing with another group of people. That's my problem with doing away with these shelter work. And, we know, at least from the requirements of the feds, is that each one of those people need to be paid minimum wage.
Yeah.
Absolutely so I'm trying to think of a nice word to say how stupid that is. But that is so disconnected from the real world, by a federal requirement. It's just hard for me to believe. I guess in the current state of Washington politics, it shouldn't be that hard for me to believe, but it's absolutely hard to believe that people think that, first of all, that they can afford to pay them $7 and I don't know what minimum wage is now, but that it's not better for them than sitting at home and doing nothing.
Right.
I'm so disconnected from that. I just can't get it.
I can tell you that's not the outcome we want to see either. And so I think this is kind of goes back to the person-centered planning initiative and really making sure that these plans are individualized to what the person wants to achieve in their life, and then the role of the provider then is to really step in and be able to meet those needs and goals. So if you have real true quality person-centered planning, that ends up being the fulcrum on which all the other services tend to rest.
I couldn't resist, and I'm going to pick up where Representative Pickert started. I'm still a little unclear why we can't say the community support waiver is going to be done by 31 December or whatever pick a date is. And I don't mean to be insensitive, and I realize it's a complex process, but I don't have any clear understanding or expectation when that's going to be done. I know the policy team is working on that, but that appears to be, using your words, whether it's the fulcrum, the lever, whatever, to make this thing go. So how and when can we get clarity on when that date certain is, if you can answer that question? Thank you.
Yeah, so there's several appendixes in the waiver, and you have to draft each one of these. Then there's a full review process, and then once we've got the entire waiver drafted, like, yes, this is the language that we're going to submit to CMS and say this is how we're going to operate the waiver. It goes out for a 30-day public comment. People, we go across the state. We want to present on this so people really understand what all is in there, what it's going to mean when it goes live, and answer all those questions. Then once we're out on that formal public comment, we have to take all those comments in, maybe potentially even revise sections of the waiver based on what we're hearing, because CMS is really, really interested on making sure that any new waiver or waiver changes do go through kind of a robust public comment phase. And that goes to CMS, and they've told us that they need about roughly a 6-month window to do their full review. And that process looks like we send it in, then they ask us a number of questions, very detailed questions. Then we answer those questions, send it back to them. They send back another list of very detailed questions that just make you want to pull your hair out. And so there's a number of just stops along this journey that just really slow and gunk up the process. But we are committed to shortening that and squeezing it as much as we can, including sending CMS sections in advance.
And if I may have the follow-up, and I get that, but I also understand project management, but do you have that mapped out? That's something you could very easily map out. We submit on this date, we allow for the Q&A or the back and forth with CMS. I think that's what, I'm not reading her mind, but I see her shaking her head yes, but that's what Representative Pickert is asking for. In my career, I've done enough project management myself to know that I can take what you just said and I can get to a date just by saying, if this, then that, then this, then that. And I think that's what we're asking for. Not to be combative or argumentative, it's just to know, here's at least an end date or a submission date. So thank you, Mr. Chair, and thank you.
Any other questions before I can? Slide 15, day supports today. What are going to go away from with the Fed rules on 14C?
In terms of can we allow for, so I don't have a really clear answer on that, because there's still some I think dust that needs to settle around where we land on definitions and leveraging some of our external partners on how other states have resolved for that as well. I know there are some creative ways that can be done, but there's no shortage of rocks and hard places that we're kind of caught between. But this isn't again, it's phase 3, so we don't have a target date just yet on when we plan to unbundle, because again, there's a whole, if it, needed to assess and understand the impacts of whatever unbundling efforts, we do take what that will do to participants in that. And if there's a capacity issue for whatever a new service potentially looks like, we've got to.
And what's the time frame to have unbundling done?
I would say it is not going to happen in 2026. I can say that for probably 2027 at the earliest, I would think.
Well, and I'm sure you've thought of this, there are a lot of other states that have been successful and had these adopted by the feds. It seems like we could get one of those and see if that met our needs and just rubber stamp it and send it in. So anyway, okay, slide 16 and then I'm done. So sorry for your patience here. And that's where it says right here, no day habilitation or work centers, shelter workshops are built into the community support waiver. I get that. I'm more concerned about what's happening now with the big waiver.
Mm-hmm.
So, committee, further questions? Representative Reeves.
Seth, correct me if I'm wrong. Right now on the day supports, that a person can go and participate in day services, and the agency providing those services, they know what is covered right now under the day supports. But have they historically had to really define what those services are? I seem to have in my memory that I spoke to somebody at one of the CDDOs, and they were saying that that's one of the things that they're going to have to learn, that if it says socialization and recreation, what is that? And that they've not really had to have really defined that.
Yeah, well, it really, again, I can't stress enough that whatever services a person is receiving really is supposed to and needs to tie back to what their individual plan states, and what those preferences and supports identified to kind of achieve that. I can say that we've had a lot of providers, because it's been so open-ended. That's honestly been a bit of a pro in a lot of ways, where providers then have been able to really be innovative in the way they're doing some of these delivery models. Like we've got we do obviously have providers more in the sheltered workshop game, but a lot of those providers are also have a really community-based wings of their program as well, that they can that folks can choose, or other providers who are, I'm going to be a day support provider and I'm just going to do like a day services without walls. We're just out and about all day, every day, doing all sorts of things. We don't want to stifle that sort of innovation on the way delivery models are presented.
Very good. Committee, further questions? Senator Owens.
Thanks, Seth. So as I've sat back and kind of listened to this, it's just drummed up another question for me. How many people in the department are working on getting this waiver sent to CMS?
Oh, I'd say it's hard to pinpoint a number. We've got our assistant IDD director. We've got a community support waiver manager already hired. They both spend a good chunk of their days on the development of this waiver. I know both myself and Commissioner Hayden are heavily involved in all of the meetings on that. Our policy and program oversight director and her staff. So it's really been kind of an all hands on deck approach.
And with the all hands on deck approach, did I understand correctly that you're thinking that this could not be submitted until 2029?
No, sorry. The community support waiver we aim to have that submitted to CMS late this year, early next.
All right. I just wanted to make sure because I was conflating some things and some concern about specific deadlines that I definitely think need to be addressed because with the amount of effort that we're putting towards this, not being able to give us deadlines is it's not sufficient. We'll put it that way. Thank you.
Well, to elaborate on that, it was supposed to be in by July. Now we're in September, and we're not even talking about submitting it now till the end of the year. So I'm kind of disappointed. And we hired a consulting company to put all that together for us. So I'm really struggling with how it's taking so long and why it's taking so long.
Well, like I said, we did have to pause there for a couple months in the spring to really work on some of these consensus work group recommendations to ensure that that stakeholders are ready and understand the overall risks to how we resolve for conflict of interest, and that's really I think the piece that's the last piece that needs to fit in there before we can finish the submission piece.
So correct me if I'm wrong, so I've heard that as long as a new waiver is conflict-free, so now you're saying that is it tied to being conflict-free throughout our entire system?
No.
Okay, just want to make sure. So how hard would it be to have a new waiver that's conflict-free under these guidelines?
Yeah, I mean, we can. I think some of the challenges we got to define some of that only willing and qualified component, right? So that's a new wrinkle in all of this. So we have to describe all of that within the waiver definition, or sorry, within the waiver drafting, and there's a lot of components on the oversight. How's the application work? How's it's the quality assurance. All of those elements are CMS is making us demonstrate that within the waiver, and they want to see some of the policy components that are going to be the department is going to take on to ensure that the waiver is conflict free. So it's not so much of saying whatever we want to say in the waiver and then trusting us. It's like you got to actually be able to put your money where your mouth is if you're going to put this in the waiver. And so it's everything downstream of that as well.
I'd certainly like to see a timeline that you could live with, just so we can hold your feet to the fire and make sure that it gets done.
Yeah. Well, I don't want to give the impression that there's not a project plan or a timeline or anything like that, because we can certainly get you something to highlight some of those components, if that would be helpful.
Well, we started on this 2 years ago, and we're almost not any closer than we were 2 years ago. So it's very frustrating, I know. Committee, further questions?
I have questions for Seth, but
Representative Ruiz.
it's really from this morning.
That's okay.
Okay. Thank you, Seth, for hanging in there with all the questions. I have a couple of questions that I kind of fleshed it out during lunch, but it pertains to the morning. And it's regarding the wait list. So I just want good clarification regarding 200 slots that we authorized last session. A family, individual gets called and said, we have an open slot. They're told what that means, and they decline. What happens?
I believe if they decline, then they then are taken off the wait list at that point in time. So we work with CDOs and families to help them really understand the risk of that choice, because you can, even if you may not feel you need waiver services at that time, but you can still get into waiver services and at least receive something, even just the barest of minimum, so you maintain your waiver slot for then that time when you do actually need more support.
And that's dependent on whether they have Medicaid or not, or it doesn't matter?
No, it wouldn't matter at that point.
They stay on the list, but maybe go at the bottom of the list.
No, they're removed so that
Totally removed.
they have to come back, basically come back through the intake
They have,
process.
okay, then they have to reapply again. Yeah, okay. And then the second question is, if I can ask a second question. Second question is, what is the notification process on being able to get in touch with a family or an individual about the open slot?
From our side, we pull we pull a list of all those folks who are going to be getting a wait list offer. Then we stratify it out by CDDO area, and we plop that into an Excel spreadsheet that then goes to each CDDO area and tell them, hey, these folks are going to be getting a wait list offer here in the coming weeks. So we'd like you to go ahead and do outreach to them, make sure contact information is all up to date, and then and tell them, let them know that, hey, they're going to be getting a letter. This is what the letter looks like. You know, it's coming in these. We've even switched recently to bright neon orange or yellow or something letter, so people really catches their eye when it hits their mailbox. And then all of the instructions are there in the letter for them to fill out. Yes, I would like to receive services. And then the CDDO is really critical in this process. Is they're walking these folks through all of the steps every step of the way.
And the CDDO is doing follow-up with them, like if they don't hear from the
Yeah.
family?
Yeah.
What kind of a grace period are we looking at?
I'd have to go back and look. But we really want to try to not harm folks who are getting offers and provide some grace, because we know it's just people live such hectic lives these days. I don't even know what I'm going to eat for dinner tonight. So I imagining what it's like living with a son or daughter with a significant disability, we know it's really easy just to miss stuff. So we try to provide ample grace to be able to get that information in and get on the
mail
waiver.
system in our rural and frontier areas they're not good in the urban areas, so it's worse in the other areas. So, yeah, if you could let us know what kind of a grace period we're looking at.
Yeah, I can get that information to
Okay,
you.
thank you.
So on that, accepting that waiver, on Medicaid, you have to receive so many services. Does that apply to waiver? You have to receive service so many, that applies to the waiver too, correct?
Correct, yeah.
So that would be an issue if they didn't need any services and yet they took the waiver but they didn't use any services for that year. They're going to lose those services. That's how it works, correct?
Right. If you're not actually utilizing any services, then technically, yeah.
So I wonder if there's some other way of doing that wouldn't penalize these people, that they would go completely to the back of the line, but yet, a year. I'm just brainstorming, but it seems to me like that's pretty punitive. I get what we're doing, but it seems like you could penalize them by not taking that service, 2 years, or I'm just saying, because again, if they don't use that service and they don't need it and they don't get it in a year, they're dropped. Mm-hmm. So that's something to think about some kind of a priority list or something that they've been offered, but they decided not to take it. But, it's 8.5 years now. It was 11. So, they're going back to 8.5 years at the end of the wait list. That's a long time to start over. Seems like we could do better than that, I would think.
Yeah, I know there are some stakeholders working on proposals on waitlist management and those sorts of things, and so we're really open to ideas and partnering with folks on ways.
Well, how about you come up with an idea and bring it to us about how that would work?
Yeah.
Would that work?
Yeah, I think we could certainly take that back and assess what potential options we've got available.
Something that was fair, get with Dr. Dean, but I think that is something that we need to work on. Committee, further questions? Senator Erickson first.
Thank you, Mr. Chair. Thank you for the presentation. Following up on this line of the wait list, that's not the way it's always been. Is it? In the past, wasn't there a different model we operated under?
I don't know that I have that information off the top of my head. I'd have to go back and check and see if there's other ways that it was operating previously.
Well, I concur very much with the chair, but here's what I would suggest as well, Mr. Chair, that we have a deadline. I don't think this is one of the issues. In my understanding, the families don't know where they are in the wait list. Is that correct? They don't know where they are. They've been on the wait list for years, 8.5 years. And I imagine it's very difficult to forecast the needs that they're going to need 8-10 years down the road. They don't know where they are on the wait list. They get this call, they don't get it, they are removed from the list. To me, that is, it just lacks common sense. But so I would like to see a plan, but I would like to see a deadline imposed for us, this committee, to see that plan, so we don't drag this out for 2 years like we've been doing with this current. Thank you, Mr. Chair.
Representative Rivas.
Yeah, I would offer that in conversations I had over lunch and some experience I had in the past, that I would think in the past the wait list was handled more of a local control kind of thing. The regional groups would kind of know their neighbors, they know the communities, and they would manage kind of their own wait list. I would suggest maybe getting back to that kind of a model. Along with that, I think we're creating our own chaos. So if I have a handicapped child that I know when they get out of high school age, I need some help. So now I get on the wait list, so I'm creating more data, more applications, managing all this stuff, when what you really need to know at the state level is, hey, in May of 2031, that this kid's going to need some help. So to me, there's a whole problem, this entire wait list thing, that needs a total revamp, and maybe get more of a local input, and maybe try to find a way to triage or stage needs. Just seems logical to me.
Yeah.
Colin, you're going to have to mention your name, where you're from.
Oh, yeah, okay. I am Colin Ornick. I work for the Self-Advocate Coalition of Kansas. I'm supposed to be speaking tomorrow, but I'll do it today as well. I'm from Olathe. I came off the waiting list in 2007, so it was a bit shorter back then. And the way it worked is you didn't know exactly where you were, but you got a letter from the CDDO. My case manager did too, and it used to be that you weren't dropped from the list. You just went to the bottom of the list, which is also not something you would want, but that is what would happen. So, and I believe the time they give you is approximately, when I've worked with Evan Dean and the people at Community Institute out of Boston, UMass, was like 15 days that you got to like determine whether you wanted services or not. And the researcher looking at it thought that was a bit crazy to have such a short time to make such a big decision. And I can tell you, when you initiate something like that, it is a big decision, because like when I came off the list, they literally gave you a list of agencies with a short synopsis, but that really doesn't tell you about what the experience is like. And for a kid coming out of high school, I was wondering, what is a group home? What is, day service? What is this? All I want is, all I was thinking is can these people help me, and can these people help me go to college, because that's what I really wanted to do at that time. I did have a job at the movie theater, and so can you support me with that? But you can't do that. You can't understand that really till you're like a couple months in, like 6 months of living somewhere. So, it is an awkward kind of thing when you're talking about high school age students or any waiver recipient. I mean, so this does need some extension, possibly, or setting up a portal where you can see where you are on the list, because sometimes it was just me getting a letter in the mail, and me and my mom were like, oh, we gotta choose something. And I'm thinking, what is this system? I've always lived with my parents and received some services which I was used to, but then you get into another set of services that you may not fully understand. Like, what is a group home, Why do I have to go here, Sort of thing for some people who have been mainstreamed in the school system are being told there's this system for people with developmental disabilities, and here's how it works now. We're making it better, but I can tell you it's still going to confuse families, and they may have limited services in their area. They may not have the choices I had. I didn't even really know my choices or how to make an informed choice. It was like my mom had experience with group homes because her first husband managed a group home for the Elks, but that was in 1974, and I came off in 2007. Grant you, this is, I'd say about 20 years after the Americans with Disabilities Act. And back then, all you really did was go to the park or something. And now I'm able to have regular employment and other things that, weren't even thought of, but we're thinking about going to this old model, which I don't even really understand, because not that the people there were bad, but I had just never understood the system. So you got to explain what these things are to help reduce confusion many times, and you have to give people more time and at least guarantee them, as Chairman Carpenter has said, some type of reassurance that if you don't choose it right then and there, you've got a bit of grace or something to, so you can like make an informed decision about where you're going to live potentially for 5 to 10 years to 20 of your life or something like that.
Colin, thank you for that. I hope you haven't used up all your testimony for tomorrow today.
No,
Okay.
it's something about.
All right. Very good.
I got something different.
All right. Thank you. All right. That's good because we don't want you to use up all your bullets today. So, Representative Pickard.
Thank you, Mr. Chair. Actually, he did a pretty good job of articulating what I was thinking, so we need to do something for people that are, like especially teenagers that are going to be aging out or whatever the term is and going to the adult services. And if they're told at age 10, their parents better get them on the list, well, there needs to be some kind of concession for them, I think. So, yeah, that's it. Thank you.
Erickson.
Thank you, Mr. Chair. Just something that Colin said, maybe Seth can answer. Is it still 2 weeks for there to be a decision made whether to accept services or not?
No, I believe we've extended that timeline, but I'll get you specifics on what that process looks like.
Okay, yeah, I'd like to know what that timeline is. Thank you, Mr. Chair.
Committee, further questions? Senator Rose.
Thank you, Mr. Chair. If the Trump administration gave you 3 months to have this work complete, would you be able to meet that deadline to save the state $300 million?
That would, that's a good question. That would require them to speed up their timeline on their end. So I mean, if they gave us assurances like, hey, once your stuff is done, we'll approve it and greenlight it. Yeah, I mean, I think we could.
Committee, further questions? So one other thing, and Seth, I appreciate you being here and taking this grilling. So, and I think I speak for the whole committee. This is not a personal deal or anything else. We're trying to make things better. And I know you guys are too. So we're just kind of feeding. But we heard so much today about being able to find out whether folks were on the wait list, what time frame, was it 5 years, 10 years, where do they go for those kind of information? Is it possible to put, or do we have it already in place and it's just not out there? But is it possible to put a phone line in or something for these folks to call and find out basic information, much like Colin was talking about too, basic information about the situation? It would be nice for them to be able to make a call and see where they're at on the wait list or what service. So is there something we can do on that?
Yeah, I think there is. I mean, I know that there are some stakeholders working on proposals right now to present to the department. So we want to be able to partner with them on kind of a thoughtful approach to that very topic. I'd also add that with the CMS access rule, we've got the CMS settings rule that was 2014. They did put out a new access rule around payment adequacy, performance measures, how states assess their HCBS. So that's a big thing coming down the pipe for us. But one of the components of that is assessing how states manage their wait lists. So I think even CMS recognizes that there's a gap, and even their understandings about how states are putting people on wait lists, how long people are waiting, how states even assess this. So we're actually waiting on some sub-regulatory guidance from them on how they'd like us to approach some of the reporting requirements on our wait list management. So
how about you get us a list of how you're going to do it and get that back to the committee?
Yeah, we can certainly take that back.
We don't really care that much about CMS unless they pay the bills, but how about if you get that back to the committee about what you're going to do as a department to increase that access and deal with that situation. How about that?
Yeah, sounds good.
Committee, further questions? Thank you again for being here, and I hope you don't take any of this personal. We're just trying to make things better.
You're all on my list. No.
Okay. All right. Very good. Thank you. Well, committee, thank you for the robust discussion. I apologize if we've digressed a little bit into other things, but I think that a lot of the things that we've fleshed out here need to be fleshed out and discussed. So I appreciate your participation in that. And does anybody have anything else as far as discussion-wise? I mean, anything from today that's on the table, that burning questions or anything like that that they would like to bring up? Senator Thompson.
I guess just one question. Legislatively, we just kind of have to wait until they hash this out, correct? Before we can go forward. We can't really do the definitions of the only willing provider, qualified provider. Is that how you see it, Mr. Chair?
Yes, it is. But I think we can strongly encourage folks.
Okay. Yeah, I get it. Yeah. I'm just curious. So thank you.
Yeah, thank you for that. Committee, anything else? Okay, I'll see you guys and girls at 9 o'clock in the morning.